Ma'am, please go ahead.
A very good afternoon to everyone. At the outset, we heartily welcome everybody for this ICOG Masterclass on ultrasound. And this episode is focusing mainly on gynecological ultrasounds. And we are extremely grateful to our dynamic Foxy President, respected Sunita Tandulwadkar, Madam, ICOG Chair, respected Parag Biniwale, Sir, Secretary General Suvarna Khadilkar, Madam, Ashok Kumar, Sir, and Secretary ICOG, Sarita Bhalerao, Madam. And I'm also grateful to the coordinator for today's program, Archana Baser, Madam, for giving us this opportunity. Now, to move further, I would like to invite and request Archana Baser, Madam, to welcome our guests so that we can formally start with the first academic session. To give a brief introduction of our all esteemed faculty members present here. Is the screen visible?
Yes.
Dipti, you forgot to mention Dr. Sheila Mane, the Vice Chair.
I'm so sorry, ma'am. Yes, ma'am. Ma'am, Ashok, yes, ma'am. And it is an honor and privilege to have Chairperson-elect Sheila Mane, Madam, also with us.
Thank you.
And the convener for today's program, respected Archana Baser, Madam. Madam is FRCOG, FICOG, and a senior obstetrician gynecologist in Indore. And she was a VP Foxy in 2020.
Just
Yes,
keep
ma'am.
it short, Dipti.
Yes, ma'am.
The academic program and everybody knows, so just keep it very
Yes,
short.
ma'am. So we welcome all.
No, you can introduce yourself one line. Just okay.
I am from Jabalpur and I'm happy to be associated in various academic programs in different capacities. Over to you, ma'am, for the welcome address and blessings by all the dignitaries.
I think, Dipti, thank you so much for helping me make this program, Dr. Mumtaz, Dr. Anshu, and Dr. Dipti. And first of all, Dr. Parag Biniwale and the team ICOG for giving us this responsibility to conduct a masterclass on ultrasound in gynecology. It was really very specific that you have to take only gynecology, no obstetrics. So I said, yes, let's choose the topics. And I'm really, really thankful to all the chairpersons who have just on my one phone call accepted to come and chair the session, and all the speakers, Dr. Dipti, Dr. Mumtaj, Dr. Aarti, Dr. Sonal, Panchal, and on everyone who has really, really accepted to be here. And I'm not going to take much time of the academic session because we all know Dr. Sunita Tandulwalkar, our President Foxy, and we know Dr. Parag Biniwale, ICOG Chair. I think they have a lot of academics under their belt. Dr. Sarita Bhalerao, Dr. Sheila Mane, the PPH lady, Dr. Ashok Kumar, also like he's going to do the next AICOG at Delhi. They all are well accomplished academician and good Foxy leaders who has been leading Foxy and taking the regular training and teaching of all the Foxians and especially the PGs by doing this masterclass and really promoting the role of ICOG in Foxy training programs. It is an academic wing of Foxy. So I would like to invite Dr. Parag Biniwale to say a few words on this masterclass and the training programs which ICOG is doing.
Thank you, Archana. Good afternoon. I bring greetings from ICOG, and it's indeed a pleasure to welcome everyone on the episode of Masterclass on Ultrasound. First of all, Archana, thank you very much for agreeing to be the convener. And with your knowledge in this field, the topics that you've chosen and the speakers who've been allotted these topics are really worth listening to. So I'm looking forward to an exciting session. Thank you all the young coordinators, Deepti, Mumtaz, and Anshu, who are going to help conduct this program. So happy learning, everyone, and I look forward to a fruitful session. Thank you.
Thank you so much, Dr. Pirag. Dr. Ashok Kumar is here. Dr. Ashok Kumar is Director, Professor, and Head Department of Obs and Gynae, Atal Bihari Vajpayee Institute of Medical Sciences and RML, New Delhi. Are you there, Dr. Ashok Kumar? I think he's not
Sorry,
there.
it's yet to join.
Yeah, so let's move on to Dr. The chairperson elect, Dr. Sheila Mane, or if Dr. Sarita and Dr.
Sarita madam, in join in between, ma'am. You can go ahead.
Yeah, so we can just go ahead with the Dr. Sheila. I could see Dr. Sheila Mane. So Dr. Sheila would like to have a few words from you, and then we can start with our academic sessions.
Yeah, sure. You want me to address? Yeah.
Yeah, just because you are president chairperson elect, and these master classes are really benefiting a lot of students and even a lot of our own Foxians. So just a few words from a great academician like Sheila Mane would be really helpful.
Yeah, thank you, Dr. Archana, and I thank Dr. Parag and Sarita for this opportunity. And I think today's topic is very important, as you said that it was said that it should be only gynec. And I think as we see now more and more gynec problems in our patients, and everybody becoming familiar with the findings and learning so much about ultrasound is very useful because your management depends on that. So I think this workshop will be very useful, in fact, for the consultants also, I feel, because now there are so many changes, You have conditions like endometriosis, adenomyosis, fibroid, and you should know how to differentiate. Then you also have to know about Roma and ovarian masses and all that. And I'm sure that Dr. Archana, you have really prepared and framed the program in such a way, I think most everybody will be benefited, and I congratulate you and best wishes for today's seminar.
Thank you, Dr. Sheila. I think you rightly said ultrasound has become like a third finger or a third eye of a gynecologist. And I was in one of the webinars before, and they say that only less than 10% of gynecologists are doing their own ultrasound. So it is very important that even if they are not doing, they learn how to interpret the ultrasound report and how to request the ultrasound to their radiologist fellows so as to come to a near diagnosis before they go for surgery or before they start their treatment. So over to you, Dr. Dipti. I hope, I've not missed any of the dignitaries or any of the office bearers from the ICOG or Foxy who are present. Is Dr. Suvarna or if they join, and Dr. Lakshmi, I think, is going to be chairing the session. So can we just start the Dr. Dipti sessions? Over to you for starting with the scientific session.
Thank you so much, ma'am. And moving on with the first session, it is my honor and privilege to introduce the esteemed chairpersons for the first session. Respected Lakshmi Shikhande ma'am, who is the immediate past chairperson of this brilliant academic wing ICOG, national corresponding editor Jogi of AMI journal as well, VP elect for she was VP of ISOPAB in 2016-17, then President ISOPAB Vidarbha chapter, President of Association of Medical Women Wing, Menopause Society, President of Nagpur OBGY Society. So clearly she has had vast experience in leading various organizations, associations, delivered more than 500 lectures, received numerous awards, Best Committee Award, publications, 62 national and 31 international publications. And this grassroots work of sensitizing lakhs of boys and girls on adolescent health issue. That is incredible. It is a pleasure and honor to have you with us, ma'am. The second chairperson for today's session is Poonam Goyal madam, who is currently chairperson Foxy Safe Motherhood Committee and also governing council member of our academic wing ICOG, also executive member of AOGD and EDGF, edited and authored numerous books and won various awards. Yes, ma'am.
You can move, yeah.
And the third chairperson for the first session, Dr. Hafizur Rahman, who is also a governing council member of this academic wing and also professor and head of OBGY at SNMIH and a clinical director and consultant at Siliguri with various other academic credentials. So we will move on with the first session. And may I please request Hafizur Rahman sir to just give a token. Rather, I think we can skip away with this introduction. I'm happy to be here, part of this session. And Hafizur sir, if you would like to say anything before we start the session.
I would like to say something about Dr. Dipti. Dr. Hafizul will read your CV that Dipti is a very sincere, dependable person. You can depend. You tell her the program, you have to do it, and Dipti will, on the same evening, she'll give you the program. So that dependable Dipti is. So
Yes.
Dr. Hafizur, you can just add on anything you want to add from her CV before she.
Fully
Yes,
agree
ma'am.
with Archana. She is really
Thank you, ma'am.
dependable. She must have called me 3 times just to remind me that I am chairing
I'm
the.
so sorry.
And I say really hats off. So Dipti, I think Hafizur is not here, so he can introduce another
Yes.
speaker.
Good afternoon, ma'am. I'm there.
Yes, sir is
So
there.
Hafizur, please introduce her in short, in a formal way. Yeah.
Yes,
Just
ma'am.
kind of Dipti.
Thank you so much, ma'am. Doctor, thank you so much. Dr. Dipti is Associate Professor Designated at NSCB Medical College, Jabalpur, and Consultant and Unit Head of Ankur Fertility Clinic, and Secretary of that is MPOX 2425.
So with
think,
your permission,
yes, ma'am. I think she is immediate past secretary of JOGS
I think we'll
2324.
move on with the
Yeah.
talks.
So over to you, Dr. Dipti. Thank you so much.
Thank you so much. Thank you so much, sir. And I would start sharing my presentation. And quite honestly, in this galaxy of stars, I feel like a toddler actually. I hope my slide is visible.
Yes, yes.
Dr. Dipti.
Please go ahead.
So the first talk for the session, going by the logic and the systematic approach, is uterus. Just a brief overview of the normal anatomy and variants. So I bring greetings from the beautiful city of Jabalpur, and we would love to welcome everybody as and when possible. Ultrasound, like Madam mentioned, that it is now considered the third eye or the third finger for every gynecologist. And Madam also rightly pointed out that unfortunately still a lot of gynecologists are not doing their own ultrasounds, which actually poses a lot of challenges. There are diagnostic issues, there are communication gaps, and then of course the patient management suffers. So ultrasound has a remarkable history wherein the diagnostic ultrasound was first documented. Its first published use was way back in 1958, and see how far we have come. Ultrasound, gynecological ultrasound to be specific, has vast number of indications, as you can see on this busy slide, right from pelvic pain, masses, numerous endocrine abnormalities, dysmenorrhea, amenorrhea, menstrual irregularities, follow-up of various cases. Of course, in infertility, it has a very, very strong role, wherein the entire monitoring and management is ultrasound based. Sometimes when there is limited clinical examination of the pelvis, then ultrasound contributes humongously. Evaluation for signs and symptoms of infection, foreign bodies, various genital tract abnormalities, so on and so forth. As far as the route of ultrasound for uterine assessment is concerned, all of us know that transvaginal sonography is definitely considered better because of better resolution, but its limitation is the limited penetration. So whenever we are dealing with a large pelvic pathology, or whenever we want to have a simultaneous false pelvis or upper abdominal assessment as well, transabdominal ultrasound certainly has a role to play. Transabdominal or a pelvic ultrasound has a limitation of that full bladder is required, limited image resolution, and of course in certain situations we may resort to translabial or transrectal ultrasound as well. There is no prize for guessing that understanding of basic physical principles, the wavelength, the frequency, the depth of penetration, the knobology, associated with the knowledge of anatomy of the area being examined is very, very important. These two are paramount. The interaction of knowledge of these two is actually going to give rise to good interpretation. And eventually we will be able to distinguish the real pathology, normal variants, and artifacts. As far as settings are concerned, once again, just like we say, कि abdominal hysterectomy पहले अच्छे से आनी चाहिए before we move on to doing NDBH or laparoscopic hysterectomies. Similarly, good B-mode ultrasound actually is the basis for all further newer modalities. So good B-mode ultrasound forms the basis for correct diagnosis, 3D rendition, capturing of images, Doppler windows. The scanning angle routinely is kept open initially for a pilot view, and once the scan overview is done, then we can change the scanning angle. Likewise, the scanning depth is initially confined to about 8 to 10 centimeters. Zooming once again, once a overview is done, then normally for the target organ, we aim that it should occupy at least 3/4 of the screen. And the focal zone is to be adjusted and gains are to be adjusted. Whenever we are in doubt, we can always use the bladder as a reference and adjust the gains so that the bladder is completely anechoic. So the principles of image orientation can be summarized as A to H, wherein A refers to adjusting of the settings, B, being beware of artifacts, safety issues, etc. C, meaning centralize the region of interest. D, adjusting the depth of field of vision. E, enlarging or zooming in on the image so as to study the area of interest correctly. F, again, focal zone adjustment. G, gain adjustment. And H, understanding the harmonics and the impact. So this is a known diagram and a known understanding to each one of us. But this is something that, again, we must remember whenever we are doing the ultrasound based on the route, the probe alignment, etc. So whenever we are doing a transvaginal scan, we first need to once again confirm there is a valid indication. Consent usually is a verbal or an implied consent. Ideally, we should be giving a brief explanation of the procedure, especially if the patient is undergoing the vaginal scan for the first time. Like often we have infertile patients, and when they walk in and we just, in a busy OPD, we just start doing the procedure. And some of them probably can go away with not so pleasant experience. We must ensure adequate privacy, ensure empty bladder for a transvaginal scan, a good lithotomy position so that the probe movements are free and easy. And preferably, if the sonologist is male, then we must ensure that a female chaperone as a nursing staff, support staff, or a female attendant should be present. We have to remember the probe alignment. Vaginal probe is always inserted with the marker towards the roof. So in almost all screens, this on the left side of the screen is where the marker should be seen, which means that the probe insertion is correct. The movements or the maneuvers, the in, out, or the advancing, withdrawing movements, the rotation in clockwise or anti-clockwise direction, the side to side. The side to side is often referred to as the spanning movement. And then, of course, the angling or the antero-posterior lift up or lift down kind of movement. So the scan, be it transvaginal or be it abdominal, will always begin, just like an obstetric scan will always begin with the first quick survey, wherein we do a smooth sweep of the sagittal plane to both the lateral pelvic side walls and a smooth quick coronal sweep. So in the sagittal plane, essentially, we are looking at cervix, endocervical canal, and the body of the uterus in continuity. And then eventually we can slide to focus the ovaries and the adnexa. And similarly, the examination then has to be done in the coronal planes as well, looking at all these organs sequentially. So this is again a diagram which is representing how in a vaginal scan, the planes are oriented. So we all of us are familiar with the anatomical planes, the transverse plane, the sagittal plane, and the coronal plane. Similarly, for ultrasound, we refer to these planes whenever we are rendering images or capturing images and measurements. So this is the default kind of picture wherein we, in an anteverted, anteflexed uterus, if the probe insertion is correct, this is the kind of image that we expect to get in a mid-sagittal plane. Uterus definitely is a reliable landmark regardless of the approach. So even if it is an abdominal scan or a vaginal scan, we expect to find the uterus somewhere around the midline. And then we can use the uterus as a reference point and look for the other organs. Fundus, bladder should ideally be on the same side. And in a transvaginal scan, we expect them to be on the left side of the screen. And the sections that we examine would be mid-sagittal coronal transfers. Broadly speaking, we are looking for the shape, symmetry, and then of course we will move on to the measurements. Once again, grossly, we try to assess whether the symmetry or the thickness of both the walls is more or less similar or not. It is very rare. In the next few lectures, we would be listening to adenomyosis and endometriosis, where we would see the difference. But generally, in routine scans, we don't really measure the thickness of anteroposterior walls. But if there is gross difference, then probably we can take the measurements. And then, of course, we have to note any deviations from normal. So in the sagittal plane, we have to first identify the correct sagittal plane, that is the mid-sagittal plane, where ideally from fundus to the external os, the entire uterocervical plane should be seen in continuity and contiguity. We should optimize the image. Then we have to examine the uterus from one edge to the other. We must be able to demonstrate the entire endometrial cavity, once again from fundus to the endocervical canal. We must also look at the endometrium and the overall myometrium from one side to the other side. The anteroposterior dimension of the uterus is also taken in this plane itself. And the endometrium again is measured in this plane at the widest point. So endometrium, I would not elaborate a lot because we have a talk in endometrial analysis as well. It is to be assessed in full length in mid-sagittal plane, measured at the widest point, calipers placed at outer to outer margin, and ensure to exclude cavitary fluid if present. And we must not forget to look for the endomyometrial junction continuity, which is a very, very important feature. Second thing, myometrium. We expect it to be homogeneous. The ecogenicity is somewhere in between the ecogenic endometrial junction and the serosal lining. So medium ecogenicity with granular ecotexture, and look for any localized or any diffuse mass lesions. And then of course we have to look for the smoothness and contour of the serosa. Cervix actually is best visualized with the tip of probe slightly away or slightly below the portio vaginalis. And then we must measure the anatomical and the functional uterocervical length. So ovaries, again, we have a talk on follicular monitoring, but generally speaking, ovaries, we always tend to reach the cornual area, then move laterally, and then probably move the probe antero-posteriorly to localize the ovaries because they may have variable positions. In normally placed ovaries without any adhesions, we expect that they should be found lateral to the uterus towards the ovarian fossa. And in an anteverted uterus, coronal view of the uterus, whenever we are capturing, again, once we reach the fundus, we can simply move the probe out and then sweep anteriorly or posteriorly to localize the ovaries. And then we measure the various dimensions. Fallopian tubes usually should not be seen unless they are distended by some kind of fluid in case of any pathology or medically. And of course, we have to be cognizant of effects of estrogen and progesterone, especially on the endometrium whenever we are reporting our findings. The rest of the uterus, mainly the myometrium, does not show much changes to the various hormonal changes. As far as the variations are concerned, so there could be variations of position, this uterus could be centrally placed or deviated to one side. There could be variations in shape, size, broad fundus, so-called bulky uterus with thickened myometrial walls, or there could be variations because of various uterine or adnexal pathologies. Disadvantages of transvaginal scan: it is not a perfect modality. It has its limitations, which are mainly limited field of view. So it is not considered best for large pelvic masses. And of course, the inability to examine false pelvis adequately. So if we have to compare transabdominal scan and transvaginal scan, then for a transabdominal or a pelvic scan, we require a full bladder, whereas transvaginal can be done with an empty bladder. There is difference in the transducer frequency, which means that the image resolution is lower with an abdominal scan and higher or better with a vaginal scan. But the other aspect is that the depth or the distance that can be covered is better with the abdominal scan and lesser with a vaginal scan. And then, of course, a very big advantage with vaginal scan is that it is kind of a dynamic assessment wherein we can actually look for the mobility of various organs and we can look and note site-specific tenderness. Disadvantages of abdominal scan that body habitus, particularly obesity, previous abdominal scars, can hamper the image quality. So choice will actually depend on the pathology suspected, the clinical examination findings, the history, and eventually if any procedure is needed. A little bit about the transabdominal or the pelvic scan. As we can appreciate in this first image, the probe alignment is vertical in the midline for a longitudinal scan or capturing the sagittal image. And for transverse sections, the probe alignment is horizontal. Here again, on a transverse scan, patient's right side would be seen on the left side of the screen. And on longitudinal scan, the cranial part would be shown to the left of the screen. So these are few basic things. Sometimes in a rush, we may be handed the probe in a different alignment by the staff. We may grab the probe ourselves in a different alignment. So these are few things that we must always remember. And we must always get into the habit of following the exactly same procedure initially. And then, of course, we can have variations based on the pathology suspected. So transabdominal scan and transvaginal scan, actually, they are complementary to each other, not competitive. This is the probe frequency. Partial full bladder helps in displacing the bowel loops above the true pelvis and provides a good sonologic window as well. And visualization of pelvic organs may be limited by body habitus and sonic attenuation, as we have already discussed. This is just a sample reporting format which can be used after modification by most of us, wherein there is a systematic comment on the uterine position, size, shape, myometrial appearance, cavity, followed by the description of endometrium. And please note that there is correlation with menstrual cycle if appropriate. Similarly, then they comment on the ovaries and adnexa, right side ovary, position, mobility, accessibility, appearance, antral follicle count, and then the measurements in all the three planes. Likewise for the left ovary, and finally the pouch of Douglas. And the good thing in this particular example that I found is the name of chaperone and verbal consent, disinfection method, signature, etc. So it seems like a very, very complete reporting which covers the medico-legal aspect as well. So to conclude, we must pay attention to the pre-scan preparations. We must always confirm all requisite details related to the patient. Not to forget the role of meticulous history and clinical examination, especially if we are doing the scans ourselves. All of us know that when we send the patient comes back with a report of, thin endometrium, say 5-6 millimeters, but there is no correlation in the report about the menstrual day cycle. Similarly, when a patient goes for an routine infertile patient, if she goes for an ultrasound, there is no comment on the antral follicle count. So which is where, doing the scans ourselves or correlating really plays a huge role. We must make sure that the implied consent is there. We ourselves need to have good knowledge of our machine, be updated. Only then and then we need to make constant efforts for good image acquisition and optimization. And then, of course, we must ensure a good patient experience. ऐसा नहीं है कि मतलब ultrasound is part and parcel, so we do it in a very rough and crude and rushed way. And then communication of results in a sensitive manner. A lot of these patients actually come with a lot of long-term problems, the pain of endometriosis, the trauma of infertility, Mullerian anomalies. So we must ensure the communication of results in a sensitive manner. With that, I would conclude my talk. These were my references. Thank you for patient listening.
Hafizur, are you here? It was an excellent talk, Dipti, because it is very, very essential to first learn the normal things before we learn the abnormal things and the variations of the normal anatomy. And you highlighted each and every aspect what we should do for the normal anatomy. And I liked it that it has to be a proper verbal consent. with the presence of one female attendant in case of a male operator. So well done. It was a fantastic talk with very good take-home messages for our audience.
Thank you so much, ma'am. Thank you, ma'am.
So I would like to add that whenever you are doing the transvaginal scan, please always do the transabdominal first, like Dr. Deepti said. And when you are starting your transvaginal, just give a slow entry to your and seeing the screen so that you can at the same time see that now you have landed on the cervix. If there is any polyp also, that will also be seen when you will become experienced.
Absolutely. Thank you for those inputs, ma'am. Moving on, I think we can move on to the second talk now, ma'am.
Yes.
All right. So may I please request Poonam Goyal ma'am to introduce the second speaker, Sridevi ma'am. Sridevi ma'am, if you can just allow me to share screen, then I would like to have your CV on display. There, ma'am.
So welcome Dr. Sridevi ma'am. She is president of Society of Fetal Medicine at Andhra Pradesh, director of Ain Donald Training School in South, and director Foxy USG Training at Vizag. And she is a fellow of Fetal Medicine, Diploma Advanced Obstetric Ultrasound done from UK, and also Fetal Invasive Procedures from Italy. Many awards to her.
Ma'am, thank you so much. But I think we should start the class.
Okay, ma'am.
Ma'am, you can start sharing again. I have stopped share.
Yeah, very good evening to everyone. First, I would like to thank Dr.
Full screen.
Yes. Just a minute. Can you see? Is it the full screen?
Yes, absolutely.
A very good evening. And first, I would like to thank Dr. Archana for this invitation. And the first lecture by Deepti was very nice. And as everyone told, she's the one who reminded me just now that the lecture is going to start and I need to be ready. And going to the lecture, I'm going to speak on the endometrium analysis. So I'm going to speak on the ultrasound, and as Madam told, unless we know normal, we don't know how to identify which is abnormal. So we are going to see how a normal endometrium has to be imaged, and we have AITA terminology, which now helped us to define everything and some of the case scenarios of the common endometrial pathologies by ultrasound. So the normal endometrium, we have to, oh my God. Yes. This is a sagittal view of the uterus where you need to start from the mid-sag and then sweep parasag on both the sides till you see the uterines where you have completed the sagittal sweep of the uterus. For the trans, next turn your probe 90 degrees and start your screening from the fundus. So this, can you see my this thing, arrow?
Yes, videos are playing. Good.
Arrow on the screen?
Yes, arrow also we can see.
Yes. So you see the endometrium, this black one is called as the endomyometrial junction. So you're seeing anterior, posterior, lateral walls, which starts from the fundus, mid-uterine body until the cervix. This is how we evaluate the endometrium. So, but when you want to see certain structure in specific, then you have to zoom the image. So here you can see all the 3 layers of the endometrium. And this is the bright line, which is the basal layer, and this midline is the cavity, and this is the functional layer. You can see one more black line beyond this hyperechoic area. This is the endomyometrial junction, which is the innermost lining of the myometrium. We all know that endometrium is the end organ. So it actually, the appearance differs with various phases of the menstrual cycle. We see this kind of thin pencil-like endometrium with some amount of endometrial fluid in the early phases of menstrual cycle to a triple line to a hyperechoic isogenic endometrium later in the luteal phase. Today, I'm going to speak more on this IETA terminology, which helps us with the terms, definitions, and measurements to describe the sonographic features of the endometrium and the intrauterine lesions. This paper is free. You can download on the internet. It is a very nice paper which gives most of the information how to evaluate the endometrium. The first question is how to measure the endometrium. So endometrium has to be measured in the sagittal plane and see where it is the widest part, and your measurement should be perpendicular from one end to the other end. From the endomyometrial junction, do not include the endomyometrial junction, from the endometrium from one side to the other side at the widest part. Sometimes what happens is the endometrium may be asymmetric, so you measure them separately and report it. Sometimes the endometrium may not be seen clearly, so don't push yourself because these are the times when you miss the pathologies. If you can't see it after menopause, please mention it. It is not measurable. That's a better way of saying that if you can't see, there's no need to say that, something we are missing, but you put it on the paper that you have seen, but you miss a lesion, that is the worst thing to happen. So the intracavitary pathology, if present, you have to include that in the measurement of the endometrium. But if that lesion is a fibroid, you should not include it in the measurement. Sometimes we see fluid like this, then you measure both the walls separately, add it up and give it. So this is how the endometrium looks. This is the lower picture. You can see there is fluid. That's why you can see both the layers separately. But when there is no fluid, you see a single midline, white hyperechoic line. This is the cavity. So usually whenever we see it is a subjective assessment, we call it as a qualitative assessment. So whenever we see something, we always compare. So what is that we compare? It is the adjacent myometrium. So if it is similar to the myometrium, it is called iso. If it is brighter, it is called hyper. Less, it is called hypoechoic. The midline also we need to see whether it is linear, non-linear, or ill-defined. But to see the intracavitary line, we need some amount of fluid, and all these descriptions are with the fluid inside, with the gel, with the saline sonogram. We can see it as a smooth or endometrial folds or the polyps or an irregular endometrium. So whenever you see a lesion, you always want to know it is a localized or an extended lesion. If the lesion is, the base is less than 25% of the endometrial surface, it is localized. And if it is more than 25%, it is an extended one. Another important feature, whether this lesion is smooth or it is like a cauliflower growth or irregular. And this is one information most of my clinicians ask when I give the scan report, because they want to plan a hysteroscopy where they want to know whether it is a pedunculated or a sessile lesion. The first one is the maximum. This A is the maximum diameter at the base of the lesion. B is the maximum diameter of the lesion. So when you divide A by B, that means if the base is thinner than the lesion, that means it is a pedunculated. If the base and this are almost equal, then it is called as a sessile lesion. So if myomas, if the most of the myoma is inside, it is grade 0. It is more than 50%, it is grade 1, and it is grade 2 if it is less than 50%. The another common thing we see is synechiae. These are nothing but you can see the islands of endometrium with the strands of tissue coming from one side to the other side. These are nothing but the approximation of the myometrium on either side. So the most important thing is the endomyometrial junction, because this is the one which separates the myometrium from the endometrium. So any lesion which is going from the endometrium to the myometrium, it has to cross this, or any lesion which is coming from the myometrium into the endometrium has to cross this. So any irregularities in this junctional zone is very important to note, because the pathologies arise across this region. When we put the color, usually in gynecology, we put the color as the power Doppler, and your PFR has to be very low, otherwise it doesn't pick. If you do scan in an obstetric setup, however, the vascular lesion, it doesn't pick up. So you have to go to a gynec setting, use the power Doppler, then decrease your PFRs to 0.3, then you get the color pickup, because these are very low vascular flows. If there is no color, it is 1. It is not 0. Please remember, it is 1. If it is a minimal, its color score is 2. If it is 3, it is moderate. Abundant flow is the score 4. And whenever we see an endometrial polyp, we always see a bright edge like this, because there's a two surfaces coming close to each other. We see some of the images how we can identify this bright edge. You can see here there is a bright edge. It is different from the surrounding endometrium. You can see here also, and you can see this video how we can differentiate that. And you can see in this video, when you put the color, we can see a nice feeding vessel in these polyps. This bright edge, you can see there's some amount of fluid. This is with the saline sonogram, so we can see this bright edge so well here. So these are solid projectile lesions from the endometrial walls into the cavity. Abnormal curve of the central line is seen because something is protruding into this. You can see the feeder vessels in these things. And you can see here the fibroids. These are again intracavitary lesions, as we know the classification of the fibroids. But what is that which helps us to differentiate these two? Usually these are solid lesions. You can see some amount of thing coming, attachment with the myometrium. And here the endomyometrial junction is intact in the polyps. And if you put the color, we can see the polyps as a feeding vessel. And in the fibroids, we see circumferential flows. So moving to the synechia, you can see this islands of myometrium with the strands from one wall to the other wall. This is a severe one, but you can see that most commonly this kind of picture, you can see hyperechoic bands when we put the saline in the mild varieties of cases. So these are fibrous bands between the endometrial walls. These are lines bridging between the layers of the endometrium. These are nothing but the myometrial wall itself. That's why the echogenicity is similar to the surrounding myometrium. 3D cavity shows the restriction of the cavity in these cases. And this is another case where we can see nice intracavity fluid is there, heterogeneous mass is there. When we put the color flow, we can see not much of the color flow in that area, but here the history helps us a lot, because this is a product, retained products of conception. So in these things, sometimes they may not tell you that there is a history of miscarriage, or they have taken medications for the MTP without the knowledge of the family members, but we won't be knowing what's happening. So history is very helpful. Once the patient is on the couch, 99% of the time they don't lie to us. And sometimes we see the picture like this. These are some of the cases of obstetrics where it's a complete more early pregnancy. This appearance is different when we see, most of the time we see little later in pregnancy where it is completely blown up, but around 7-8 weeks we see this kind of picture. And this is another case where you see there is fluid, but you can see a synechia also. Then you can see cystic areas. This is a partial mole where the gestational sac is formed, but there is no fetal pole, and you have multiple abortions. So synechia is also there, and the molar changes in the this thing. So you see thickened endometrium with small anechoic areas. Complete transformation of chorionic tissue into the vesicles is complete mole, but the partial conversion is the partial mole. In gynecology, we come up with this situation where the endometrium is thickened, but what is that we want to look at is along with the thickness, this black line, which is called as the endomyometrial junction. So any thickness more than 14 mm in premenopausal and more than 5 millimeters in postmenopausal, you need to do your survey better, and EMJ is well maintained or not, and color flow has to be put. So this is one case of postmenopausal bleeding. When we put saline, we can see, because it's looking like, cystic endometrium, but we can see nice polyp, and this is a benign polyp because that was not much of the color pickup in ultrasound. It was a simple hysteroscopy with the grasp, but they could take it. I'm almost done. And this is the thing. See, there's no color pickup, and all around the polyp we can see the fluid. So this is the advantage of putting little saline inside these cavities, which helps us to know what kind of lesion it is. This is another case where the endomyometrial junction is so irregular. Whenever we put the color, there is good pickup of color. We didn't want to put a fluid inside this, but this turned out to be an adenocarcinoma. So thickened endometrium, localized or generalized, heterogeneous structure with or without fluid in the cavity, EMG obliteration, especially the color Doppler with heterozygous distribution of the vessels is very, very important, which helps in picking up these lesions. So the reassuring features here is the thin endometrium, 3-layer, linear midline, and single vessel without branching is very important. So to end, I think I have covered all the endometrial pathologies from pregnancy to the infertility and to the postmenopausal. But if you do a scan, it is very easy to pick up if you do it in a systematic manner, starting from the endomyometrial junction to the endometrial echogenicity, midline, and the cavity. This is how we need to do it with the zooming of the image, which is about 2/3 of the screen. I think we cannot miss these lesions. Thank you.
Absolutely wonderful, Dr. Sridevi. You have, I think, covered each and every point in endometrium. But just I would like to say the novice people who don't do their own ultrasounds, whenever their patient is on the table, just get in your head that what you are expecting, whether you are expecting secretory endometrium or proliferative, or what you are expecting, what is the day of the menstruation. And once you learn the normal, then you will be seeing your pictures were very clear and wonderful. I think must have benefited many people. Thank you.
Thank you so much, ma'am, for the kind words.
Excellent talk, Sridevi. It was excellent. I think you did justice to the topic, and you are making my life difficult because I'm projecting such beautiful talks and slides.
No. I should thank you for inviting me, Dr. Archana. And it's always nice because I think this is the only way. See, there's so many people who have logged in, sitting somewhere. Many people can learn this way. So you people are doing a great job.
Thank you, Sridevi.
Thank you so much, respected ma'am. And now I would like to request Lakshmi Shikhande ma'am to invite our next speaker, Dr. Archana Baser ma'am, for the last talk of the first session for today.
Thank you, Dipti. It's always a pleasure to introduce and welcome dear friend Dr. Archana Base. We all know that she's a great, great academician. She was Vice President Foxy in 2020. She was Organizing Secretary of AICOG 2021 Indore. And you can see that her interest in this masterclass on gynec ultrasound, because she has dedicated 3 years to the Foxy Imaging Science Committee, where Archana, you really did some fantastic workshops and CMEs. So I invite you to speak on myometrium. That is also very, very important to know before we go ahead and see the myomas and the adenomyosis. So here, platform is all yours.
Thank you, Dr. Lakshmi. Thank you so much for kind words. And may I be allowed to share screen? Yeah. And I will go to, can you see my screen? But I have to make it full screen.
Yeah.
Is my screen
Yes,
visible?
ma'am.
Yes, ma'am. The screen is visible. Just need to have the slideshow mode.
I'll go on the slideshow. It's not coming. Just going on the slideshow, just wasting the time. Right, yeah. Yes.
Great.
Yes,
I'm all
ma'am.
set. So thank you very much, ICOG, for giving me this opportunity to organize this masterclass on gynec ultrasound. And believe me, we are really handpicked all our speakers, and you will really you'll enjoy the talks. And Dipti and speaking after Dipti and Pri Devi, I'm finding it little, difficult because they have taken few of, there will be repetition a little bit, but let's listen to the myometrial pathology. What I always tell in my talk that you can visualize endometrium by hysteroscopy, you can visualize serosa and uterus by laparoscopy, but the myometrium is visualized only by ultrasonography. And myometrial pathologies play a very important role in your abnormal uterine bleeding, may it be infertility, may it be pelvic inflammatory disease, may it be malignancy, because myometrium is something which is very, very important. So pelvic sonography is the imaging modality of choice for evaluating myometrial pathology. So we all know we have been talking about sonography, and advent of vaginal sonography and color Doppler sonography have allowed for major refinements in detection and accurate diagnosis of common disorders affecting uterus, particularly myomas and adenomyosis. So let's understand what is normal before we are able to pick up abnormal. Dipti has taken it very well, and she has really told us in detail how to hold the probes, how to examine. But just for those who have joined a little late, that this is the outer myometrium, inner myometrium, and we all were talking about this endomyojunction, right? So this is a very, very important thing when we talk about adenomyosis and any other pathology. And this is just a histological view of endometrium and myometrium. This is the ultrasonographic anatomy, what has been learned before also, just it's a master class, so we can have a little revision. This is the serosa, this is myometrium, and this is endometrium. And if you see what happens, the distance between the anterior wall and the endometrium, this layer, and the posterior wall and the endometrium is almost equal. So this we will highlight why we are talking about this equality in the diameters here, and when we are looking at the myometrium and endometrium. So this is how the stratum functional is. This is the functional endometrium, this is stratum basilis, and this is the inner myometrial junctional zone, which is being illustrated here. And these are the myometrial layers, because we are talking about the myometrial lesions. So we just have to see them, what are the myometrial layers. So this is the inner junctional zone, this is the middle, and this is the outer layer of the myometrium here. This is again the normal anatomy, serosa, there is a blood supply in the myometrium, this is the endometrium. And what you see here is a loss of endomyojunction. What you see, the uterus shape has become a little globular, what people say it is a, enlarged uterus. And you see here, you can see a picture, this patient presented, may present with like infertility or present with abnormal uterine bleeding. You don't see a good endometrium, like Dr. Sri Devi has just demonstrated beautiful endometrial pictures. There is no endometrium, there is no endomyojunction. There is a loss. And let me tell you that adenomyosis is very common in Asian women compared to the other ethnic groups. Normal endomyojunction and triple layer endometrium. So this is how is the normal endomyojunction, and this is a triple layer endometrium. What happens in adenomyosis? It is a common benign uterine pathology that occurs when the cells that normally line the uterus also grows into the layer of muscle in the wall of the myometrium, and the area of uterus affected by adenomyosis is known as the junction. So this is all is your adenomyosis here. Now, incidence of adenomyosis, it is asymptomatic in almost 1/3 of cases. Menorrhagia, dysmenorrhea, pelvic pain, and uterine enlargement. Role in infertility is still debated, but reported frequency in infertility is almost 1 to 14%. Now, like you have to always differentiate between myoma and adenomyosis. What happens? Myometrium is generally isoechic. It is similar to the liver and homogeneous. The myometrial echogenicity, thickness, contour, and presence of any mass or cyst are noted during ultrasound examination, and the two commonly encountered pathologies of the myometrium are fibroids and adenomyosis. So what are the features, ultrasound features of adenomyosis? First clue to adenomyosis is often an ill-defined lesion within the myometrium. Lesion may have an irregular contour, no rim, no edge shadow, or a fan-shaped shadow. Other features may include myometrial cyst, hyperechoic islands, subendometrial lines, and Bird's translesion below flow, and a thickened, irregular, or ill-defined junctional zone, and myometrial anterior-posterior asymmetry, an enlarged uterus, and vascular arrangement is radial and penetrating. So these are three key signs on ultrasound. One is the ectopic endometrial glands manifest as an echogenic nodule and striations radiating from endometrium into myometrium, muscular hyperplasia and hypertrophy. This appears as a globular uterine enlargement and asymmetrical myometrial thickening, often with thin vention blinds or streaking shadowing or salt and pepper appearance, and hypervascularity. Adenomyosis increases uterine vascularity, which shows up on color Doppler as a pattern of penetrating vessels. It is important to distinguish these from peripheral vessels, which indicates the presence of fibroid. Again, I have already taken this asymmetrical thickening, globular shape, ill-defined EMJ, linear striation, and increased junctional zone thickness on 3D more than 8 millimeter. So look at the pictures now. So this is a picture where you see the loss of endomyojunction. This is the normal endomyojunction. On a 3D, you see a nice endometrial cavity with endomyojunction. You can clearly see this, and here there is a loss of endomyojunction, and this is a normal endomyojunction. Loss of endomyojunction on 3D can be very well appreciated again in this picture. This is a normal anatomy, normal endomyojunction, and where here there is everything look sprayed up, like how the picture, the pixels, when you take a picture from your camera in a mobile, like how the pictures when you enlarge gets into, like sprayed. So something like that. And this is a very typical picture of adenomyosis. What is the main difference between adenomyosis and fibroids? Adenomyosis, the shape of the uterus, though it enlarges, but it is maintained. While in fibroids, because of the irregular fibroids, the shape is distorted. While here, the size is enlarged, but the shape is maintained. And look here, this is an endometrium. What I was talking in the first slide, that this distance from this wall to the endometrium and this to this. So learn when you're doing ultrasonography, normal ones you learn how to measure the distance of the anterior wall from the endometrium and posterior wall from the endometrium. You would be able to pick up your adenomyosis. And another thing which you can appreciate in this picture is your myometrium is not homogeneous. Like it is a heterogeneous myometrium. You can see these are if I'll put color, they'll be like a blood vessels, and you can see either it's a vention blind or a salt and pepper appearance. This is kind of a focal adenomyosis here, but how to differentiate it from the fibroid once you know to measure this anterior and posterior wall difference. Then there is a color peripheral supply in the fibroids, while sprayed up blood supply in the adenomyosis. This is what is called is what I am talking. This purple line is a myometrial asymmetry, and these are the linear striations, and there is a no endomyojunction and globular shape. All four features of adenomyosis we have tried to pick up in the one picture. What is the differentiation between fibroid and focal adenomyosis? as I said, central vascularity and associated features of adenomyosis are cyst, indistinct myometrial EMJ, no contour abnormality, and no age shadowing. Look at a beautiful picture of the fibroid. What you see here, there is a peripheral, what you say, the capsule of the fibroid, it can be seen, while in adenomyosis, it's an ill-defined capsule. This is a focal adenomyosis here, and there's a ill-defined capsules are seen. If you talk about the vascularity, this is a peripheral vascularity here, while here there's a diffuse vascularity in adenomyosis, and the diameter of the vessels, when you measure, is very big in adenomyosis as compared to the fibroids and other pathology. Now, there's a spectrum of adenomyosis. There are several kinds of pictures you can get when you are scanning adenomyosis. There's a globular shape. Look at the endometrium, just distorted, and this is the shape of the uterus in the transverse section, and this is in the sagittal plane. Then this is again the blood supply of the adenomyosis, and these are like some challenging cases also in adenomyosis. Once you have learned that when you are scanning, you have to see the myometrium and you have to see how to differentiate between the fibroids and adenomyosis. These are the challenging cases. Uterus is like pushed. Some might report it as a endometriosis because you see ground glass appearance. But when you look here, when you do the transverse section, this belongs to the uterus only, not to the ovary. This is an adenomyotic cyst. So different kinds of presentation in adenomyosis. There can be adenomyotic cyst, there can be focal adenomyosis, there can be diffuse adenomyosis. So this is a very typical case. This is again a focal adenomyosis. What I was talking about, the diameter of the vessels, it is quite big in adenomyosis. And this is again a Venetian blind appearance of adenomyosis. Just brought one case to highlight like how the adenomyosis presents, and it can be a challenging to treat as well. So this is a 27-year-old female. We come with heavy periods and prolonged bleeding. She wanted to conceive. No other comorbid condition, average build, AMH is low. She has a HSG done, which was normal. Her husband's semen parameters were normal. Look at her picture. This is an adenomyotic cyst. Again, shape of the uterus, quite enlarged uterus, endomyojunction is not visible, and this is a adenomyotic uterus with an adenomyotic cyst. Adenomyotic cyst is a very specific diagnosis of adenomyosis, and which can be picked up. I'm not going through the details because I have very little time left with me. So, I mean, it is challenging how to manage her. So we put in a Mirena to her, which has really helped her in reducing her bleeding. And when we scanned her day before yesterday, her size of the uterus also little smaller than before, and adenomyotic cyst also shrunk a little bit. So then this is again the same patient, just to highlight how the adenomyotic cyst appears. And then what happens with the adenomyosis, you will be analyzing the whole pelvis whenever you are doing a pelvic sonography. Adenomyosis comes with maybe endometriosis. They are like cousins, you can say. So you must look at the ovaries, and these ovaries are small, adherent, and MRI or ultrasound for adenomyosis is a question which frequently being asked. So transvaginal ultrasound is superseding MRI for diagnosing adenomyosis due to its wide availability, low cost, and quick exam time. I'm just finishing. Sensitivity to transvaginal ultrasound in diagnosing adenomyosis is 80% and specificity is 60%. I'm not going to go into the fibroids because we are running out of time. And just so just a learning point from my talk, adenomyosis is defined as presence of ectopic endometrium within the myometrium. Pelvic ultrasound is a preferred and reliable diagnostic modality. We all can learn it. MRI is an accurate tool for diagnosing an associated condition. Adenomyosis can be diffuse or focal. The most established, MRI finding, just for you to learn, know that is thickening of junctional zone exceeding 12 millimeter and high signal intensity myometrial foci on T2 or T1 weighted images are also characteristics. So with all this, I would like to thank, and I appreciate your patience listening. If there are any questions, I think ICOG allows some time between the session 1 and session 2 for the questions. so
Yes,
that
yes, yes.
we can have some
Yes,
questions.
Deepti, you can just see the chat box and the questions. If there are any, you can ask
So
all the.
there are no questions. I've just
As of
checked.
now, yes.
My
As of
first
now, no questions. I think all the three talks were so clear, but still, if there is any, they can
I
put
mean,
in the chat
if
box.
chairpersons have any questions or
Yeah,
any
Archana, you
inputs.
did a wonderful job. You explained the normal myometrium, the adenomyosis, the fibroids, and how to differentiate between the two, and also the focal adenomyosis, the diffuse, and also the adenomyotic cyst. So I'm sure our delegates must have learned a lot and lot about the myometrium, the endometrium, and from Deepti's talk, how to do a TVS in a normal, I mean, what will be a normal feature in a transvaginal ultrasound. So your first session was too good, Archana. Well planned module and well
Thank you.
chosen
Thank you.
speakers.
Thank you. Actually, the planning was done this way that, go systematically from
Yes.
serosum, normal, then myometrium, and then now you come with the advanced, like, all they will be talking about the different pathologies, so that it builds up like how to go. And our whole motto is that gynecologists should learn to do the sonography, or if not doing, at least understand the sonography
Yes.
better, so that we can really help help our patients. So any Diptish, we are before time, means like we are setting up ICOG's new standard times. So if our speakers are there, you can really go for the second session. Or if
Yes,
any of the
ma'am.
speakers, Sri Devi, do you want to have any comments, or Dipti, if you want to make any comments, we have 2 minutes more left.
Ma'am, I think probably we can, with everybody's permission, move on with the second session. And if
Okay,
we are
that's
still on
great. I
time,
mean, I think at the end we have
Yes,
time.
yes, yes.
yes.
Delegates
Dr.
can
Lakshmi,
comments in
Dr.
the chat box. Speakers can answer their queries in the chat.
Yes, in the chat box.
It's
That
a
saves a lot
ongoing
of time.
learning session. I mean, 3 hours, it's
Yes.
just a learning process.
Yeah,
Yes.
so thank you, Dr. Lakshmi. Thank you, Dr. Poonam, and thank you, Dr. Hafizur, for chairing our sessions, and really, Dipti, for carrying it very well and on time.
Thank you so much, ma'am. There is one question in the chat box right now from Dr. Rohini that sometimes there is difficulty visualizing the uterus in adenomyotic scans. Your comments on this?
Yes, it is, because it becomes like, there's something called comma sign. Uterus become retroverted. As I said, endometriosis and adenomyosis are cousins. So adenomyosis per se is not going to, it's just only going to enlarge the uterus. But because of the heaviness, it gets retroverted and it becomes difficult. And maybe if it is endometriosis associated, it becomes very difficult. You can only see the cervix, the uterus goes at the back. So maybe in such cases, get the bladder full partially and uterus will get up. And then, as everybody said, that do a transabdominal scan. Whenever you are scanning pelvic pathology, do not entirely, I mean, transvaginal is very good, high resolution, everything is so close, but still the transabdominal has to be done. So you will be able to pick up. Yes, I agree. It becomes difficult at times to find out the uterus direction, and some newcomers say, oh, I can't see the uterus. So it
So
is.
that is where Dr. Deepti what said that first you do the transabdominal scan, then I think the things will become better.
How I do it, Dr. Poonam, if the patient has come in OPD, like how in our practice, and if she's already full bladder, I say don't pass urine, I will do your transabdominal first. And if she has already passed urine,
Yes,
I do the
yes.
TVS and make her fill the bladder and do transabdominal. Means you have to
Yes.
do both, but you can't waste the patient time twice and ours also. So you have to invest your time depending on the
Smartly.
situation. Yeah.
Yes. Okay. And now a lot of questions are popping in. So if you can spare a few minutes to reply in the chat box, ma'am, we
I'm
can move
replying.
on with the second session.
Okay.
Dr. Dipti,
And
move on with the second session.
yes,
Yeah.
ma'am. For the second session, to conduct and convene the second session, I would like to invite a very senior gynecologist, senior teacher from Kerala, Dr. Mumtaz Madam, who's professor and unit head at the Department of OB-GY, MES Medical College in Periyanthalmanna, Kerala. And it is a pleasure and honor to have you with us, ma'am. And I would be sharing the screen for the CVs now, and you can take over.
Thank you, Deepti, for that difficult pronunciation of Perintalmanna also. Good evening, respected seniors and dear friends. It's a proud privilege to be here today as a coordinator for this session. I thank Dr. Archana Base ma'am for this opportunity, and she's the master brain behind all this talks here that is happening today. And as we move on to the second session, we have three eminent chairpersons, Dr. Shobha Gudi, Dr. Pratik Tambe, and Dr. Komal Chavan. So first of all, let me introduce Dr. Shobha and Gudi. Madam is very close to all of us. Like we have been listening to her on many occasions. She had been a speaker in our own webinars also in Kerala. And Madam is the president of BSOG in 2018 and chairperson of Family Welfare Committee. She is like a multifaceted personality and has served in many positions, including the organizing secretary of IMSCon 2020, scientific charitable. There's so many things.
Thank you. Thank you,
Awarded,
Mumtaz.
society award and all that.
Yeah.
So
thank you. I think we shall move ahead. Thank you so much.
Us today to as a chair for this session. Deepti, please, next slide, please. And Dr. Pratik Tambe, sir is done all the training from abroad like France, Belgium, and Singapore. He's an aortic consultant and endoscopic surgeon. And sir is currently the governing council member of ICOG from 2000.
That should be enough. Thank you. Thank you for inviting me.
Welcome you to this session, sir. And Dr. Komal Chavan, our own VP for this 25, Vice President of FOXI 2025, also the chairperson of Medical Disorder Committee. She was the Medical Disorder Committee chairperson and also the zonal coordinator of FOXI. Madam is the medical director of Chavan Maternity and Nursing Home. Over to you. I'm welcoming you as a chairperson for this session. I would request Dr. Shobha Gudi ma'am to introduce Dr. Sonal Panchal and move on with the session.
And thank you very much. Thank you very much, Mumtaz, for that lovely introduction. And here in ICOG, we actually function under a very wide umbrella. So we must thank Dr. Sunita Tendulkar, Dr. Suvarna, but also very importantly, Dr. Parag Benivale and Dr. Sarita for this wonderful opportunity. And I'm especially delighted to introduce the person who is known as the encyclopedia of gynecology. And it's very true, whatever everyone has been sharing so far, that a gynecologist has to be it's more like a endogynecology or sonogynecology it has become today. We all of us have to become adept at this. And thank you for organizing such a wonderful session, Dr. Archana Base. We are really grateful, and Deepti, Mumtaz, you are doing such a wonderful job of it. So I take special delight in introducing Dr. Sonal, consultant, Dr. Nagori Institute for Infertility and IVF, made a niche for herself as a very acclaimed expert in this field. Of course, she has several degrees to her credit. I will not state them because it is like showing the lamp to the sun, not necessary. I would like to say that she has a very high number of publications in impact journals, and has been a very prolific speaker and has kind of authored a lot. So I think her books are worth going over if one wants to read, one wants to become a good sonologist in gynecology. And of course, her special interest is infertility. I've heard a number of occasions her talks on infertility, and what she's speaking today, HICOC, is very important, very significant. So the floor is yours, Dr. Sonal.
Thank you very much, ma'am, for those very kind words. Thank you very much to the entire ICOG, all the office bearers, the entire team. And thanks very much to Dr. Archana, my very close friend. If there is, her request is like an order to me. I have to follow it. She's so dear and near. So starting with the presentation on HICOC. Moreover, yes, I also need to thank Archana for giving me this topic, which is truly very close to my heart, and very happy to say that The picture of hycosis that you're seeing here is a HD live silhouette image of hycosis. And this is what I started. I was the first one to do this in entire India. And I started this way back in 2012. So, and it's gone a long way now. So if we talk about the fallopian tubes, we know that the fallopian tubes can be divided into 5 parts. The intramural part, then comes the isthmic part, then the ampullary part, which is slightly, variable in diameter. And then you have the fimbria and you have the infundibulum. So yes, it is true that we anatomically do divide this into 5 parts because all the 5 parts have different wall anatomy and has a different function to do as such. We will not go into that detail, but because we have to, because every part of the fallopian tube is important, it is also important to understand what is the total in total function of the fallopian tube. Yes, it is true that when we learned anatomy in the first MBBS, we all learned about the function of the fallopian tube. And we know that they play a very active part in fertility. But beyond that, when we entered into the gynecology and especially into the practice, we sometimes in our very fast routines, we forget that it is not just sufficient to assess the patency of the tubes. We need to assess the function of the tube. Why? Because fallopian tubes are not just portals to the gametes from the uterus and the other way around. They actually play a very active role in the transfer of the gametes. This is probably only one tube in which one gamete, the sperm, traverses from the uterine end towards the mid part of the tube, and the ovum, which is another gamete, traverses from the fimbria to the mid part of the tube. So there's a movement in 2 different directions, and therefore it's important that it's fully coordinated. Moreover, it is also responsible for the transfer of the embryos. If we talk about ovulation also, so that is an additional function. When we talk about ovulation, we all know that it is not, the ovum before the ovulation occurs at the ovulation site, the tube comes and the fimbral end of the tube comes and overlies the ovulation site. And there is a ciliary movement which occurs in the tubal lumen, which leads to negative creation of a negative pressure about -1 millimeter of mercury. And because of that negative pressure, the thinned out area of the follicle, which is just underlying the fimbral end of the tube, breaks, and the entire follicular fluid is taken up by the tube, which also contains the cumulus oophorus complex, which just before the ovulation has been released into the follicular fluid. It is therefore that the negative pressure which is built up in the tube is very important. It is for that the correct position of the femoral and over the ovulation site which is important, and it is for that purpose that the tube-ovarian relationship have to be normal, the femoral and has to be healthy, the inner mucosa of the tube has to be healthy, so that the movement of the gametes and the embryo become smooth. And therefore you do understand now why it is not just sufficient to know that the tubes are patent. We need to see them actively working. We need to see the femoral condition. We need to assess the tubo-ovarian function. It is therefore that any of the imaging techniques truly is not a sufficient technique. If we are thinking about HSGs, we know it is a static method and we cannot evaluate the tubo-ovarian relationship, or you cannot even evaluate the femoral condition. When we are using ultrasound, of course, we can do a dynamic examination, but still when we are using negative contrast, the assessment of the fimbria and the tubal lumen is difficult. People have therefore advanced to the positive contrast and the 3D techniques. And let's see what is the role of ultrasound into the assessment of the tubes. When we assess the tubes with ultrasound, it is very important to understand that the tubes have a very tiny lumen. They have a very scanty fluid in the lumen. It's almost like a potential space, and it is therefore that it's very, very difficult to evaluate the tube either from inside or from inside when the outside, when there is no fluid either inside the tubal lumen or outside. If the fluid is inside the tubal lumen, we know it is abnormal. We call it a hydrosalpinx. And if it is outside, of course, it may be because of ovulation, but it may also be present because of PIDs, or it may be because of any other pathology. Sometimes also without pathologies, just because of high estrogen. The additional problem with the tubal evaluation is that the tubes are mobile structures, they're free floating structures in the pelvis, and therefore they may or may not be seen in a single 2D plane always. So to find out this abnormalities, there are certain modifications which had been done in the ultrasound technique during the assessment of the tubes. And this have resulted into several different procedures. As I told you, we need fluid either inside or outside the tube to evaluate the tube, and therefore started with this. It all started with a saline procedure. We'll discuss it out. Then came in saline infusion salpingography, which is by using saline, which is a negative contrast. Some people used saline alone with the 2D ultrasound. Then came in Doppler. Some people used saline with air, and ultimately came in the positive contrast hysterocontrast salpingography and the hysterofoam salpingography. Sign procedure is a very simple procedure, though is not at all popular, and I'll tell you why. This was invented in the Sign Hospital by our own our very own known ultrasound specialists. What was done was about 100 to 150 ml of normal saline was pushed into the peritoneal cavity. Through the cervix, the catheter was put. Through that, the fluid was introduced into the uterus. That fluid will pass through the tubes into and would be released into the peritoneal cavity, which would allow us to beautifully see the femoral end of the tube. And you can very beautifully differentiate here the normal fembria here and the pruned fembria, thickened fembria here. So these are the normal fembria and these are the thickened abnormal fembria. So yes, if we could collect fluid in the pelvic cavity, we could judge that yes, at least one of the two tubes is patent and you could see the femoral quality. Yes, of course, if both the tubes are patent, the fluid entry would be much more easier. And many a times you may be able to also see the tubo-ovarian relationship as you're seeing here beautifully on both the sides. But there was a lot of fluid to be introduced, and therefore that fluid remained there for a very long time. It became a very painful procedure. Sometimes pain lasted for quite a few days, and a lot of chance of infection. And therefore, this method was not very. It didn't become very common. But after that, people started introducing a much more limited amount of fluid and focusing on the femoral end of the tube or around the ovary to check for the fluid collection, and that became much more popular. The procedure, as a rule, of course, you have to rule out vaginal infection, should be done between day 6 and day 10. The bleeding has stopped, but the ovulation has not occurred. Asepsis is important. If there is infection, the patient must be treated for the vaginal infection, cervical infection first. And then you introduce, the fluid can be introduced through either a sonohysterocannula, or you can introduce it through the 6 or 8 French Follis. The balloon is distended in the uterine cavity because we are doing this assessment to evaluate the tubes. Then you are going to concentrate on the image where you can see the uterus in the transverse section, and you can see the ovary in the transverse section on the same image, and then the fluid saline is injected through the Follis catheter into the tube. As you do that, you may see the fluid trickling from the femoral end of the tube and then collection of the fluid posterior to the ovary. This would tell you, yes, the tube is patent, but this is not always possible. The femoral end of the tube may be in front or back of the ovary. You would only see the fluid collection posteriorly. That's when you would not know which tube is patent. Yes, but if both the tubes are blocked, that's when you would get distension of the endometrial cavity and no fluid collection, which would tell you that both the tubes are blocked. Lots of advantages have been named, have been listed for the CIS, but it has been considered as an initial investigation for the infertile patients. You can delay the laparoscopy till about 6 weeks, and you can also meanwhile do the endocrinological and immunological assessments. There are a lot of people who compared it to laparoscopy, to HSG, etc. But we know the major disadvantage is we cannot know which side is the block, where is the block, and we also don't know anything about the intratubal pathology and even intratubal adhesions, and motility cannot be assessed. Therein started the use of the color Doppler. The color Doppler box with the same image, transverse section of the uterus, transverse section of the ovary on the same image. You are going to switch on the color box as you start injecting the fluid through the same Follis, and as you inject the fluid, you would see a color blush filling up the color box here, as you can see, which tells you that tube is patent. So yes, you can either introduce the fluid slowly, continuously, or you can introduce it with a short jet. Presence of the color blush tells you the tube is patent. If not, it is not patent. But you cannot see the lumen. So therefore, people started injecting air. And when the air was injected, that's when the bubbles were created. You can see the entire tube, but air is a risk of air embolism and was not preferred. Positive contrast were therefore used. Positive contrast can be created, can be reconstituted by mixing the powder along with the solvent. You create a foam, and then that foam is being introduced through the tube. If you use contrast mode, you can see the entire tube along with the femoral and details of the femoral end. But if the tube is not entirely in the same plane, that is when you may doubt a block. It is in this cases that you can use a 3D ultrasound, and 3D ultrasound plays a very important role. It has very similar results to laparoscopy, and therefore can be used largely, but it is ultimately an imaging technique. Yes, you can see the femoral details. Yes, you can see the block. You can see that the condition of the tubal lumen. But if you find anything abnormal, if you don't find normal femora like this, if you find a block, that is when laparoscopy is absolutely essential. Two important signs: showering sign, contrast may be seen showering, or a ring sign, ring of contrast surrounding the ovary. Apart from the filling of the tube and the spill seen are the additional signs which tell you, yes, the tube is patent. It is considered as a primary investigation for the tubal evaluation. And after that, if the patient doesn't conceive after several cycles, for 3 to 6 cycles, you can go ahead with a laparoscopy. Thank you very much, and sorry for exceeding by 1 minute.
Yeah, that is quite okay. I think the information given was so much needed and quite new to many of our audience. So I think this much time was quite okay. And you brought out the fact that this is a much higher sensitivity than the hysterosalpingography you feel, and probably it is less invasive, right, Dr. Sonal?
Yes, it's not
Yeah.
at all invasive. In fact, I mean, yes, it is invasive, but it is not at all painful. It can be done in the OPD setup, and you do not require actually any special equipments for
Correct.
that. Which I didn't tell you, which was in the slide, but I did tell you was this days, instead of using that positive contrast, which is Sonoview, people are also using lignocaine gel, and 4 ml of lignocaine gel can be diluted in about 15 ml of saline, and that would also be a very useful method to create foam And because it's a local anesthetic, it causes less pain and produces the same pictures. That is even more economical.
But it is quite safe for the
Yeah, there are
endothelium.
lots of
Yeah.
publications on the same. Lots of publications on the
That's
same.
of great value. Yeah. So, do you have any studies which you have published on this? And
Yeah.
that will be my
There
last
are
question.
studies there. I
Yeah.
mean, probably have been mentioned,
That's
but yeah,
wonderful.
there are lots of studies.
Yes.
We use semen media, sperm media.
Yeah, there are people who are using betadine, there are people who are using sperm media, people are using different things, but lignocaine already has sufficient literature proof.
Okay. That's a very nice, very new trick you taught everyone. That's very nice. Thank you very much. I think,
Thank you.
Mumtaz, you can take to the next speaker now. Yeah. Hello, Mumtaz.
She's not there, so I think I'll go ahead. Let me
Yeah,
begin by
please go ahead,
expressing my
Pratik.
gratitude to the
Okay.
ICOG office bearers. Congratulations to the convener, Dr. Archana Basir, and her team, Dr. Deepti Gupta, Dr. Mumtaz, and Dr. Anshu Basir. I am here to introduce Dr. Meenu Agarwal, who is well known to all of us. She's the vice president elect of FOXY, past president of the Pune OBGYN Society. She served as the Imaging Science Committee chairperson when I was the FOXY Endocrinology Committee chairperson in short while ago. And she is also well known to us in ART and endoscopy circles. She also conducts several courses in ART and endoscopy as well, both in India as well as abroad. She is here to speak to us about follicular monitoring, which is a much needed art for anybody who's passed out from their basic MBBS MD and are now thinking of branching into fertility practice. Over to Dr. Meenu Agarwal.
Thank you, Pratik. Thank you for this kind introduction. I call you my rock, and he has always been very helpful to me. So thank you for the entire ICOG team for organizing this nice master class on follicular monitoring, especially my friend and my previous chair of Imaging Science Committee, Dr. Archana Basir, and of course Parag Biniwale, Sarita Bhalerao Madam, Dr. Sunita Tandurkar, President Foxy, and everyone who's associated with this course. So now I shall be talking on follicular monitoring. It is a very simple thing. However, I will just take you through the nitty-gritties of the technique. As Dr. Archana Basir said, and previous to her, Dr. P.K. Shah sir, Dr. Pardesi sir, who have been in imaging science, everybody had the advocacy that every gynecologist should be able to do a good pelvic ultrasound. It is a difficult road, it is a difficult journey, but then uh, at least for the newer students, it is better. For us, it was actually quite difficult. The patient is much more comfortable, less anxious, and we as gynecologists, we are comfortable doing a transvaginal sonography. Many a times we send to radiologists and they do abdominal and they say no, patient does not want transvaginal. So that also challenge is there sometimes with the radiologist. Time management is again one thing. Suppose I am doing my own scanning and I know when to start gonadotropins, when to give HCG, depending on the size of the follicle or my ultrasound findings. However, if the patient is going to another place for ultrasound, informing me the reports, sometimes it does not go very well as far as the timings are concerned. Just a few things how to prepare the vaginal probe. Uh, Very important one thing is that we just close to the ovulation should not use jelly, use normal saline. Just take normal saline in a syringe in one hand, push the normal saline. Before you take out the syringe, keep the vaginal probe there, take out the tube and insert the probe simultaneously so that the saline becomes the interface, and jelly can get little more messy, if especially if it is a timed intercourse today she has ruptured, so that becomes little difficult. So what all do we see? I know this has already been covered, so I will just take one minute for these slides. If you find thick endometrium, like here, looking like a thick endometrium, how do we know it is polyp or it is just a thickened endometrium? So what we do is we keep a normal IUI catheter always in our OPD.
just push a little normal saline inside, and now here you can see a beautiful polyp floating. And if we put a color Doppler, we can also know whether there is a single vessel supplying to the polyp. If there is a blood vessel supplying to the polyp and you do go for a hysteroscopic surgery, for my junior colleagues, very important that you must coagulate that vessel at the base of the polyp. Otherwise, that polyp is going have 40 to 50% chances of recurrence. Adenomyosis, fantastic lecture by Dr. Archana Baser. Just one slide, that whenever you find one wall of the uterus thicker than the other, mostly the posterior wall, it, unless you prove it otherwise, it is adenomyosis. And you may also have some cystic spaces in the myometrium. Endometrioma, dermoid, just like balls filled in a bag. uh, Also, any hydrosalpinx. See, whenever you're doing a follicular monitoring, you're not just looking at the follicle rupturing and the good endometrium. If it is a hydrosalpinx, I mean, I'm sure the tubes have already been checked, but if not, we must also rule out any hydrosalpinx, pyosalpinx, dilated tubes. So that is again important. And if we find a fibroid, a good mapping of the fibroid, again very very important, that you have and you know exactly where the fibroids are and any isthmocele which is present. Again, for my junior colleagues, whenever you have a patient who's had a previous C-section, even though she is not having any postmenstrual spotting, bleeding, foul smelling discharge, look for an isthmocele, because many a times it may be asymptomatic in 50% of the patients, but your eyes will get tuned to looking at the isthmocele, and then you, when it is required, you will be able to point it out. So in infertility, what we do? First, we do a baseline ultrasound on day 2 or day 3. So what do we do at that time? Most important, we look at what is the antral follicle count, how is the endometrium, is there any ovarian cyst? So these are the three things that you would look at the baseline ultrasound. Now, baseline ultrasound, when you see, what we are seeing are these antral follicles. These antral follicles are developed in the luteal phase of the previous cycle. Okay, so I say AFC count 3, 6, 10, 11, whatever. These are the follicles which have come up from the luteal phase. Then comes the selection phase. So in the selection phase, what happens? 2 or 3 follicles become bigger and the rest remains small. Okay, so it is not yet selected, right? So it is the selection phase, which is on day 5, day 6. Then around day 7 or day 8, you will find a dominance phase. That means the one follicle starts becoming bigger and bigger. Out of the selected follicles, one follicle which become bigger and the other follicle will undergo atresia. Now, sometimes out of the selected follicle, the smaller follicle can become the dominant follicle. The dark horse goes ahead, becomes the dominant follicle, and other follicles they are left behind. Now, very important for all of us to understand is, if I have to start gonadotrophins for a patient, when do I start gonadotrophins in an IUI cycle? When I see a follicle which is more than 14 millimeters in size, or if I have done the E2 values are more than 50 picograms per ml. That is when I should be adding gonadotrophins. If I add gonadotrophins somewhere here or somewhere even in the selection phase, when there are 2 3 follicles coming up, you may have more than one follicle. In the older group of patients, because there are a lot of aneuploid oocytes also, you can still start a little earlier and you can aim at getting 2 or 3 mature follicles. But in younger group of patients, I think 1 or 2 follicles for IUI or for timed intercourse is good enough. In cases of thin endometrium, when I have to start the estrogen, again, at this stage, when we have the dominant follicle is producing its own FSH. And this FSH is giving a negative feedback. It is producing its on FSH and also estrogen, and the estrogen is giving a negative feedback to further production of FSH from the HPO axis, right? So the other follicles are not getting any food. This follicle is very clever, it is producing its own FSH, it is also producing estrogen ताकि बाकी follicles को negative feedback मिले. So this follicle is growing nicely. So if I have to add estrogen for a thin endometrium, this is the time, even if I add estrogen, it will not give an antagonist action, and this follicle will keep on growing. Now, this follicle grows at about 1 to 2 millimeters per day. It can reach 18 to 20 and sometimes 24, 25, 26 also at the time of ovulation. And as the dominant follicle grows, the number of smaller follicle, it comes down. Now, then once the E2 values go up, it is causing a negative feedback for FSH, but at a certain value of E2, 200 to 250 picogram per ml, it causes a inhibition of the negative feedback for LH. That means it causes a LS surge, and this LS surge will cause pre-ovulatory changes. This is a halo here, this is a cumulus over here in folding of the follicular wall. Now, again, very important. Suppose I do the ultrasound today. This patient is for IUI. I find these are the findings. So, what should be my next step? My next step would be to check for her LH. So, I can do urine LH or I can do a blood serum LH. If her urine LH is positive, that means she is already triggered. The SUG trigger is already, the LS surge is already there. So, I should do IUI today or tomorrow and not depend on HCG and then 36 hours later. So if I have to give HCG, it should be much before the pre-ovulatory changes come. But if this follicle is already getting to rupture, then I should plan my IUI timing depending on the LH. If the LH surge is positive, then within 24 hours I should plan. So what happens at the time of ovulation? There is a little bit shrinkage of the follicle, blurring of the follicular borders, and then there are echogenic areas in the follicle. Now, again, it is very important that it does not collapse. The follicle just disappears. No, it just shrinks in size with some echogenic areas, some fluid in the pouch of Douglas, and then if you see after a week or so, you will find the endometrium will become secretory like this, homogeneous all around, and this is the corpus luteum which will be formed. And if she does not conceive, this corpus luteum turns into corpus albicans and becomes dormant. Then, of course, we have to correlate both the follicle and the endometrium. So, don't look at only the follicle. 16 hai, 17 hai, 18 hai. We also have to look at the endometrium. So, how the endometrium is growing. What is the endomyometrial junction? Again, the endomyometrial intact endomyometrial junction, very, very important. So, the endometrium also grows 1 to 2 millimeters per day, and by the time of ovulation it is more than 8, sometimes 9, 10, 11, 12, and this is how the secretory endometrium. So if you see endometrium becoming like this, this is fluffiness all around. If there is fluffiness all around, you see a pre-ovulatory or just follicle is about to rupture, that means this is the time that you have to do IUI or timed intercourse. Do not wait for 48 hours, 36 hours, give HCG and wait for 36 hours. You will have missed the bus. She will have already ovulated a day earlier. So that is again very, very important. How to grade the endometrium? Now, this is a grade A endometrium where this intervening area is as hyperechoic as the anterior myometrium. And this is grade B where it is less, the echogenicity is less here as compared to here. And this is a grade C or the homogeneous. Now, if it is homogeneous, ovulation time है, follicle दिख रहा है, E2 किया, E2 is say 250, but the endometrium is looking like this, that means you probably this patient needs a hysteroscopy, because E2 is there, but it is probably not reaching the cavity. So this is the ideal one, but we can get a pregnancy even in grade B. Then, of course, we also divide it as the vascularity zones. What I have realized, if you have a good endometrium like this, a good triple line endometrium, 10 mm in your measurement, then even if you don't put a color Doppler, means it is logical that because the blood supply is going nicely, that is why the endometrium is growing, right? However, if the endometrium is not good, suppose your E2 is good, but the follicle is good, but the endometrium is not grown, then those are the cases which require we need to check for the maybe a hysteroscopy you need to do and check out what is the problem. Then of course, some sound, okay. Then of course there is some troubleshooting. Sometimes you may find a large follicle, okay, on day 4, day 5, day 6, day 7. So this is you do the E2 values. E2 is low, you put the color Doppler, it is a thin wall, so then that means this follicle is of no use. If there is another follicle which is lying next to it, you follow that follicle and you can forget that follicle. Second, very important is the unruptured luteinized follicle. Sometimes, we get lot of IT patients, Pune being a very IT city. You get patients where they do their LH test at home, which is fine, absolutely okay. Not getting pregnant, they come to us, especially patients who have mild endometriosis, PID, mild to moderate endometriosis. You find the LH is positive. Okay, the endometrium becomes secretory, but there is no free fluid. There is echogenic areas in the follicle, but it does not reduce in size. There is no shrinkage of the follicle, no free fluid. So these are cases of unruptured luteinized follicles. What to do for these patients? We can, of course, one option is to go for a laparoscopy. Maybe they have mild to moderate endometriosis or some kind of a pelvic adhesions, or these patients we can give antagonist. So when we see in the next cycle, when you see a dominant follicle 14 to 15 in size, that is when you start with antagonist. The moment you give antagonist, it will also suppress the FSH along with LH. So you also give gonadotrophins. So you give gonadotrophins, you give antagonists for 1 or 2 days or 3 days till you see a nice follicle 18 in size, 17, 18, 19, and then give the trigger with SCG. For all of you, all my colleagues, junior colleagues, do not use agonist in IUI cycles, because your pregnancy rates will really go down. Agonist is only for the freeze all protocol in cases where we are going in for a IVF cycle. So if you give an agonist trigger, is not meant to give SCG trigger. PCOS, I think if I don't have time, I will not take it up. But of course, always differentiate. Whenever we are doing an ultrasound for a follicular monitoring, this is not PCO, this is multifollicular ovary. So look at the stroma. If it is a thick echogenic stroma, that is what is the PCO ovary. And in these patients, the ovulation will, your induction of ovulation will change. If they are not responding to letrozole, metformin, in those cases, we can go for a chronic low dose gonadotrophin. Start with 37.5 units every day. Give it for 5 days. After 5 days, do the ultrasound, do the E2 values, and if you find a dominant follicle, then continue with the same dose. And I am done. Thank you very much. So this is all. I will just skip. So all right. So all right. Okay. So this is how we measure. And so only 3 things we should remember: atretic dominant follicle, which is not going to ovulate, ovulatory dominant follicle, and unruptured luteinized dominant follicle. So the role of E2, very important in follicular monitoring in selected group of patients and timing your IUI. Thank you very much, and sorry I took a couple of minutes extra. Thank you so
Thank
much.
you, Dr. Meenu Agarwal, for highlighting the importance of baseline scan and then taking us through the entire journey of follicular monitoring. I think it was an eye-opener for all of our audience. Thank you again for being here with us, and I hand over to the next chairperson.
Thank you. I would request Dr. Kamal Chauhan to introduce our next speaker, Dr. Aarti Tolani.
Yes, thank you. Thank you so much. I think fabulous talks in this session by Dr. Sonal and Dr. Meenu. And congratulations to Dr. Parag Biniwale and Archana Baser for this wonderful masterclass on ultrasound. And now I call upon the next speaker, Dr. Aarti Deendayal Tolani. She is a clinical director, fertility specialist, scientific in charge at Mamta Fertility Hospital, and associate editor of Minerva Gynecological, that is Italian Journal of Obstetrics and Gynac, secretary of Telangana ISAR, faculty of the Kiel School of Reproductive Medicine, Germany, and she has a lot of publications, almost 30 in national and international journals. So she is going to talk upon case studies in infertility, and that will be really interesting. So over to you, Dr. Aarti.
Thank you, Dr. Komal, for that introduction. And can I just share my screen? Request.
We can see
Can
your
you see
screen.
my
Yes.
screen?
Yes, we can see the screen. Just make it full screen.
Right, right. So thank you for that introduction. And just before starting, definitely want to congratulate the organizing committee of the ICOG Mastering Ultrasound series, which is being held right now for conducting this CME. And thank you, Dr. Archana, for having me here. It's really an honor. And in this 15 minutes you have given me, I hope I can do justice to the topic which has been allotted to me, and which is just case studies in infertility, and a disclosure before I start, and that is my talk is just the tip of the iceberg. What ultrasound actually has to offer is much more. It's timeless and limitless. So I'm just presenting the tip of the iceberg of what ultrasound has to offer in the field of reproductive medicine. And the purpose of my talk is to show you how ultrasound can solve clinical dilemmas and how ultrasound can actually offer solutions through case stories and through pictures, which can speak much more than 1,000 words, and through videos, which can speak much more than 1,000 truths. I hope I can do justice to this session. So the topic is case studies in female infertility, and how I intend to share my experience is show you the case, the tools you need to come to a diagnosis, very simple action steps to be taken, and finally take home messages. So how I've created the map of my talk is I'm going to take you through quickly various scenarios covering uterine pathologies, ovarian pathologies, adnexal pathologies, infective pathologies, and endometriosis, starting with uterine pathologies. So let me tell you the story of this patient we saw in 2005. She was a 28-year-old medical professional, 5 years of subfertility, chronic anovulation, came for ovulation induction, has taken several self-medicated cycles, and an endometrial biopsy was done a few months back because she had menorrhagia and there was disordered proliferative phase which was noticed. Now, if you look at this ultrasound picture, you're not able to really make out the junctional zone over here. And then when we put on the Doppler, what we saw was a thickened endometrium with chaotic vascularity at the area where there was loss of the endomyometrial junction. And this is the diagrammatic representation, the chaotic vasculature where the junctional zone was not well defined, and the patient, being a doctor herself, insisted on getting a biopsy done under hysteroscopic guidance because her previous biopsy was absolutely okay, and we insisted on getting, on doing a biopsy, and this is what we saw on hysteroscopy. And biopsy was taken and it showed adenocarcinoma. So this was the first shock there. Patient went in for a hysterectomy, and this was a poorly differentiated endometrioid adenocarcinoma with infiltration into the middle third of the myometrium. And what we also saw were tumor deposits on the left ovary. Now, why am I sharing this case? Because we were so focused on the endometrial pathology that we saw that this was the elephant in the room, and we missed out on looking at the ovaries and what was present in the ovaries. So the lessons learned: don't take your young infertile patient for granted. And when in doubt, use Doppler, because here, just based on the Doppler, we suspected there must be some pathology, did a biopsy, and then I just showed you what happened to this patient. And don't have a tunnel vision. When you see a pathology staring at you, don't have the elephant in the room approach. Look around at the other organs in the pelvis and look for other associated pathology. So that was one of the cases which taught us so many lessons. Now moving on. We all know how a typical endometrial polyp looks like. I'm not going to go into the detail. This picture speaks it all. But let's look at what we are seeing here. Now, if you look at this patient here, she was a case of secondary subfertility, known case of PCO, and you could see this large polypoid structure within and filling the entire cavity, and this bright edge echo over here, which is the interface between the intracavitary lesion and the endometrium, tell us that this is a polyp. But what is more noticeable here is that there is again a loss of the junctional zone in the posterior wall, and it looks like there's an infiltration of this pathology into the myometrium up to the serosa. Now, what did we do next? Again, we put on our Doppler. And this is just a diagrammatic, again, representation of what we saw. And Doppler again showed chaotic vascularity, and this was a polyp with a malignant change. Again, moving on quickly, this was another patient we saw, 41-year-old nulliparous woman, 25 years of subfertility, and we saw a thick endometrium. This was on her day 16 of her cycle. She had menorrhagic cycles. She was on homeopathic treatment. Again, chaotic vascularity. And look at what else we saw. Now, the tunnel vision, we did not only focus on the pathology, we moved away, did not have a tunnel vision, looked at the ovary, and we're looking at over here a multiloculated, solid looking lesions in the ovary. And the ovary was quite enlarged in size. The endometrial volume also was on the higher side. And you can see this was a patient who had a well-differentiated adenocarcinoma with an adult granulosa cell tumor. And this again is the diagrammatic representation. And it's important to note over here that very large multilocular solid masses are very often associated also with endometrial carcinomas. And this is very important to note that when you see a pathology in the endometrium, also look whether the source of the estrogen is coming from the ovary, which in this case, this patient had a granulosa cell tumor. Now, this was about different uterine pathologies, take-homes being, look at the junctional zone, put on the Doppler, and don't have a tunnel vision. Also look at the ovaries, whether there is also associated pathologies in the ovaries. Now, moving on to different ovarian pathologies, which we have seen. As I mentioned earlier in the talk, this is just the tip of the iceberg. This was a patient who came to us, diagnosed with PCO and a right ovary also showing a solid appearing lesion. Now she's come with this report and hirsutism and acne as well. Now when we did the ultrasound, yes, we saw a well circumscribed intraovarian solid mass in the right ovary, well-defined borders. The left ovary looked polycystic, but look at what we saw when we put on the Doppler. Chaotic vascularity, both central and peripheral vascularity. This is how the 3D image looked. And in those days, this was way back in 2014, we applied the IOTA adnex model. And what came out is that most probably this lesion was benign, but 4% chance that it also could be metastatic. Now, when we got this information from the IOTA adnex model, we just got curious and just palpated the breast, and we found a solid mass in the breast. And when we did a breast scan, there was an irregular solid mass with lobulated borders with posterior acoustic enhancement. And this, my dear colleagues, was an intraductal carcinoma. And in all probability, we were dealing with a metastatic tumor. So ever since, our clinical examination and reporting has changed. So the lessons learned from this case was use newer technologies and softwares, of course, to impress your patient and yourself too, but more importantly, do a thorough breast examination for every patient who comes to your clinic, even if you are an infertility specialist. Now, moving on to another case we saw. Now, if you look at this case, this patient actually came to us in the middle of stimulation elsewhere. And she came for a second opinion to know whether her stimulation was going well. And we were shocked out of our guts when we saw absolutely abnormal looking solid adnexal mass, and you could actually see the ovary with the growing follicles over here, and you could see that there was a breach in the surface outline of the ovary. And this was how the Doppler looked. There was increased vascularity. And this was how the transabdominal ultrasound appearance of this abnormal solid mass around the ovary looked. And there was ascites when we looked in the Morrison's pouch as well. And again, when we, put in, when we use the IOTA adnex model, they were all features, all M features, and we were clearly dealing with an ovarian malignancy. And when we persuaded and asked the patient for a little more history, she provided this report of a recent surgery she got done a few months ago, where she was diagnosed with a borderline papillary serous neoplasm and also peritoneal deposits as well. So she went in and got her stimulation done with another center without revealing all these facts, and again came to us for a second opinion. And because we were shocked with what we saw and asked her for her history, she then provided these reports. So what was the lesson learned from this case? Patients may not tell you the truth, but your ultrasound cannot lie. Actually, it will expose the truth. So this was a lesson we learned. Now look at this interesting case. In the ovarian pathology series I'm taking you through, this patient came to us for an IVF cycle. She had failed an IVF elsewhere. We did the IVF. She had a laparoscopic myomectomy. I'm just rushing through the case because there's so much more I want to show you through the images and videos I have in my cases, which I want to show you all. We did an IVF, embryos were frozen. First embryo transfer was negative. She wanted to lose weight, come back. She took a gap and came back for again planning the second frozen embryo transfer cycle. And look at what we saw. We saw solid appearing bilateral ovarian masses and with a color score 2. And this is how it appeared on transabdominal ultrasound. And she did not have any family history of ovarian cancer or any cancers for that matter. She was absolutely asymptomatic. She just took a break, lost weight, came back for her second FET cycle. Again, when we used the ORAD's ultrasound calculator, clearly it showed that it was a malignant ovarian tumor. We sent her for an MRI, which showed here bilateral solid ovarian neoplasms, likely sex cord neoplasms. And a laparoscopy was done with a surgical oncologist. A staging laparotomy was done, and the histopathology did reveal ovarian cancer. And look at what came out, that they suspected that it was a Krukenberg's tumor. And in view of the above, immunohistochemistry, a primary gastric malignancy was suspected, and that is when the gastro was brought into the picture, and upper endi. Can I go ahead? Dr. Komal, can I go ahead?
Yeah, I think you can wrap up this case, I think, because we will have to finish.
Sure. So upper GI endoscopy was done, and there was a mass in the stomach. Colonoscopy again showed a mass in the stomach. So this case actually taught us that ultrasound findings can sometimes be so shocking. It won't even correlate with your symptoms. She was a simple infertility case coming for treatment to us. But again, over here, your ultrasound cannot lie. This patient is undergoing chemotherapy, and actually ultrasound exposed the truth of the matter. So this was the ovarian, pathology series. I'm not going to go into more number of cases. I'll just quickly go through some adnexal pathologies and videos. I want to take you through different appearances of a hydrosalpinx. This is a thin-walled hydrosalpinx. Thick-walled hydrosalpinx may probably be pyosalpinx, and 3D reconstruction always helps in understanding the nature of the tube and whether there is a terminal block, and newer rendering engines can also be used to sort of identify hydrosalpinx. And infective pathologies, this is just last 2 minutes, and I'm just quickly taking you through these slides. When you see endometrial interruptions and you see calcifications, these are all, again, just telltale signs of an infection within the endometrial cavity. I'm just quickly going to go through and go to my last slide. The lessons learned. I could only take you through the case series we have seen in the ovarian uterine series, but lots of lessons we've learned from each case. And this is my mentor who has taught the whole team and so many students she has taught in her lifetime. The lessons she has learned from ultrasound, and that is, do a good ultrasound for your patient. The ultrasound is telling you the diagnosis. Ultrasound helps in displaying the whispers and magnitude of the disease. It guides our next focus and plan of action. With ultrasound, we give the patient choices and not judgments. And most importantly, a young gynecologist starts a career with 20 tests for one disease, but when an experienced one who has realized the importance of ultrasound knows that there is one ultrasound which is enough to diagnose 20 diseases. And this is the take home, that you cannot practice well enough, efficiently enough, and patient-centric enough without the use of ultrasound in your daily practice. And I cannot thank my patients enough who teach us lessons every day on how ultrasound helps us. Thank you.
Yeah, I think lovely talk and very, very nice series of cases. Very interestingly, actually, I was so much engrossed in your presentation. I really wanted you to go on, but we have lack of time, and that was there. And what I can appreciate more is a diagrammatic representation which followed every ultrasound image was very fabulous. We could actually go and find out how it would look in when we open up or operate on that patient. So that gave us very much insight. Really nice presentation. I would really like to see the complete presentation sometimes. And definitely regards to Deen Dayal madam also. It was a pleasure to see her working. So excellent talk, Aarti.
Thank you, Dr. Komal. Thank you. I just
Aarti,
stopped my share.
Yeah, Aarti, it is an excellent talk. Excellent. I mean, I heard this talk before, and I really wanted you to give this talk on this platform, because it's very important when people are learning and focusing on ultrasound on one subject, they should see, not have a tubular or tunnel vision. So excellent talk, and you really finished it so fast in time. So thank you so much for coming for us.
Thank you. Pleasure is mine. Anything for you.
Thank you so much. You're my dear friend, and I know all my friends are here today on the ICOG platform. So thank you so much.
Thank you.
Aarti, very, very nice talk, very nice cases, crisp videos and pictures, images. Excellent as always.
Thank you, Dr. Meenu. I enjoyed all the talks which I saw in the short time I was there, and I'm looking forward to hearing all the remaining talks as well. Thank you.
Thank you so much, Archana madam. Our pleasure to be part of such an interesting session.
Thank you,
Thanks so much.
Archana, for inviting us and excellent
Thanks, Pratik.
evidence-based talk so far. I'm sure there's more to come.
Dr. Deepti or Dr. Anshu, whosoever is taking over now.
Hello, hi everyone. All right, I'd like to share my screen now. Nilima, can you help me with that, please?
Hello.
Hello. Hello, hi everybody. Hello.
Done, ma'am.
Okay. All right. So, hello everybody. I'm very. Am I audible? Hello.
Yes, Anshu, you're audible.
Hello everybody. Thank you for having me here, and thank you, Dr. Deepti, for for helping us and guiding us in organizing everything. So, if my screen is visible, without further ado, I would like to move on to the next session and introduce the chairpersons for the next session. So the first chairperson that we have is Dr. Vidya Thobi. Ma'am is the Foxy Vice President elect 2025. She's the president of KSOG 2023. She's been the chairperson of Food and Drugs and Medical Surgical Equipment Committee. She's also received the Best Committee Award. So we're very happy to have ma'am here with us. Our next chairperson is Dr. Rajendra Singh Pardesi. Sir is very well known. He has been a faculty at FIGO 2006, Kuala Lumpur. He's been a faculty in ICOG 2021. He was VP, Vice President Foxy, Vice President AMOG, and was President AMOG's 2022-2024. So we welcome Sir to this wonderful session. Now, the next chairperson we have is Dr. Preeti Kumar, and she's a chairperson of Maternal and Perinatal Committee SAFOC 2023 to 25. She's the Vice President North Zone Elect Foxy 2026. She's a chairperson of Safe Motherhood Committee and committee member of MFM Committee in ICOG and the president of Lucknow Obstetric Society. So, we're very, very warm welcome, ma'am, to you to this session. And
Thank
I
you,
would
Anshu.
like
Thank
to
you.
hand over to our chairperson, Dr. Vidya, to introduce our next speaker for the session, Dr. Mumtaz.
Thank you,
Before
Dr.
Dr.
Anshu.
Vidya, before Dr. Vidya speaks, let me tell you one thing is missing in her CV, which is very important, that she is Vice President-elect Foxy 2026.
Yeah, that is a missed typo error there. So
Okay.
thank you very much, Dr. Anshu, and I really congratulate Dr. Archana for bringing out such a brilliant ICOG masterclass on USG. Thank you, Foxy President Dr. Sunita Tandulwadkar, ICOG Chair Dr. Parag, and Sarita Bhalera, who is a secretary. Such a wonderful things we are listening since afternoon. And after this, and it is nicely the sessions are such a nicely organized that we are learning a lot more from each stalwarts who is a speaker here. So after understanding normal and abnormal, we are listening to evaluation and monitoring. And now we come to a special scenarios, and for which the topic now, Dr. Mumtaz, who is speaking now, is on endometriosis. We all know Dr. Mumtaz very well. She's a professor, unit head, Department of Obstetric Gynecology, MES Medical College, Perintalamma, Kerala. And she has got many awards to her credit, like Kalyani Kutty Memorial Gold Medal at all Kerala Conference. And she has organized various conferences as well as CMEs. And I very well remember that she has organized one of my CME also. So welcome, Dr. Mumtaz, to this prestigious ICOG masterclass, and you will be throwing some light on endometriosis, which is very difficult to diagnose on ultrasound. So over to you, Dr. Mumtaz.
Thank you, madam. Shall I share the screen?
Please make her, I think she's already co-host, so she can share her.
Please share.
Yeah. So I would like to express my sincere thanks to Archana ma'am for this opportunity, and also Parag sir for this brilliant ICOG masterclass. So as Vidya ma'am told, it's a difficult diagnosis. And we know the incidence is rising. And like all roads lead to Rome, there are many multifactorial reasons why someone would get endometriosis. And the effect of endometriosis is also multiple on different organs with different symptoms. And like the arms of an octopus, it touches and crushes actually the life of the woman with multiple morbidities, and sometimes can even cause a difficult life all through her reproductive age. Now, when we come to the diagnosis, now the clinical diagnosis, our 2 fingers have been like almost replaced by the transvaginal probe. It is the primary tool we have for diagnosing endometriosis, and the endometrioma is the one which catches our eye in most of the cases. And sometimes we think endometriosis is equivalent to endometrioma. And when we open up or when we do the scope, it is a frozen pelvis and we are stuck. So the diagnosis and history, diagnosis from history or clinical findings, or sometimes even ultrasound is like a maze where we do not have a correct direction to know what exactly is the problem. Sometimes a patient with multiple deep endometriosis are totally asymptomatic, and a woman with minimal disease has severe pain and infertility. This tells us that we need to look beyond the endometrioma, and this classification is a surgical classification, which is not much of help when we are looking into a pre-operative assessment. So now we have this new classification in NCR, which is focusing on deep infiltrating endometriosis and also the retroperitoneal structures, which helps us in preoperative assessment and can be used for our surgical planning. So here, the whole area is divided into 3 compartments. A, that is vagina and rectovaginal septum. B, the uterosacral ligaments up to the pelvic wall, and the rectum and sigmoid colon comprising the compartment C. This classification prefixes its number. I'm not going into the details of this classification, but it looks specifically into the peritoneum, ovary, tube. This is the primary objective of this, where we have to look for in enzyme classification, but also more importantly, the deep endometriosis. So in everywhere, what is the size? What is the location? Whether it is in the peritoneum, whether it is the ovary, whether it is a tube that is in the pelvic side wall. And when it comes to deep endometriosis, A denotes the rectovaginal septum, the uterosacral ligaments, the rectum, and F is about the adenomyosis, bladder, intestine, ureter. So it can affect in a varying, but not just confined to the uterus and ovaries. So one thing about ultrasound is that our eyes do not see what our mind doesn't know. Do we have a protocol to do scan in gynec? Yes, we have the MUSA. And according to MUSA, we know it is focusing mainly on ovary and uterus, and it is a static imaging technique also. But that is not enough when we are thinking about endometriosis. We have the new one, that the IDEA consensus, that is International Deep Endometriosis Analysis Consensus Group. According to that, they are given much importance to dynamic imaging also. And the static imaging is also beyond the uterus and adnexa. So again, there are 4 components in this idea, that is evaluation of uterus and adnexa, dedicated search for deeply infiltrating endometriosis, assessment of sliding sign, and there are some soft markers also that we need to look into. The static findings are how the uterus is, which I'm not going into the detail. Archana ma'am has covered it in detail. Coming to the ovary, it is the most important site of endometrioma, and this would be the typical picture, but we should also remember that there can be some atypical finding also, some cysts with fluid levels, hyperechoic material, and sometimes a nodule also. And coming to adnexa, we know there is peritoneum and also the tubes there. So here we have to focus on whether there is hydrosalpinx, hematosalpinx, and any peritoneal inclusion cyst. So the tube will be distended as a tubular structure in hydrosalpinx. And in hematosalpinx, there will be low-level internal echoes in these dilated tubes. And also we can see sometimes inclusion cyst in the peritoneal cavity, where ovary will be eccentrically placed and there will be additions which is where the collection has got enwrapped and has formed an inclusion cyst. So the static imaging of this compartment would be to look for an adenomyoma, which is usually found in association with endometriosis. Look for hematosalpinx, the endometrioma, hydrosalpinx. Now coming to the compartment 2, we have to search for deeply infiltrating endometrioma because that makes a difference in the management. So anything that is extending beyond or greater than 5 millimeter into the peritoneum or with organ invasion or retroperitoneal involvement is called a deeply infiltrating endometriosis. Sometimes we can use a 3D volume calculation also to know the exact size and measurement of these lesions. How to look for this? Again, we have to divide this into an anterior compartment, which is from the anterior uterine serosa to the anterior pelvic wall, and a posterior compartment, which is from the posterior surface of the uterus to the posterior pelvic wall to the sacrum. So in the anterior compartment, we have the bladder, which is the most common site of urinary tract DIE. About 90% of these cases will be in bladder. So in the bladder itself, the dome is the commonest place. So how to detect this? It is ideal by a transvaginal sonography with a bladder partially filled and look for a nodule, which is usually present in between the uterus and the bladder and will be pushing into the bladder. But when we see a mass in the bladder, our differential diagnosis will be bladder malignancy, but the malignancy has irregular papillary projections and will be very vascular and will be protruding into the bladder loop. And posterior compartment, we have to look into rectovaginal area, bowel and uterosacral ligaments. And we know rectovaginal endometriosis is very troublesome both for the patient and for the surgeon. So look behind the uterus and adjacent to the bowel for the rectovaginal space. And we should also have a basic understanding about the bowel anatomy. Which area are we going to look into? The upper anterior rectum is above the peritoneal reflection and below the uterine fundus. And the sigmoid is above the level of the uterine fundus. And the rectosigmoid junction is at the level of the uterine fundus. This is the usual anatomy. And when there is the rectum and rectosigmoid junction is the commonest site of intestinal endometriosis. The uterosacrals divide rectum into lower rectum and upper rectum. And this will be a picture of bowel endometriosis, how it will look like. The nodule here, as you can see, the arrowheads, this is the nodule, and the white arrows are denoting that is just pushing into the posterior vaginal wall. And uterosacral ligaments can be visualized easily when there's a small amount of fluid also around them. So it is hyperechoic in contrast to the retrocervical hypoechoic nodular or linear thickening that occurs when there is a lesion. So here you can see this is the uterosacral ligament, and this nodule there is the endometriotic nodule here as depicted in this picture. This is the uterosacral ligament. Now the component 3 is assessment of sliding sign. So maybe bladder endometriosis, if there is a mass in the anterior pouch, it is easy to diagnose, but bowel and rectosigmoid junction is little bit difficult. You need a higher end machine, you need experienced hands, like somebody who is experienced in doing this kind of ultrasound is also important. But next 3 components, that is a sliding sign and looking for the soft markers, will help us. Even if you don't have, even if you don't diagnose, you don't see a nodule in the rectum, these 2 things are going to help us think that there could be a bowel involvement or there could be a rectosigmoid involvement. So in transvaginal ultrasound, you assess the movement, that sliding sign. Does the bladder move in relation to the uterus? Does the cervix move in relation to the rectum? Does the uterus move relative to the bowel? That's what we are going to see. So with one hand on the suprapubic area, the other hand in the transvaginal, with the transvaginal probe. This is the ICOG video on this. So in the first, we can see it is moving irrespective of the bowel and the bladder. That's a positive sliding sign. But in negative, everything is moving en bloc. Everything is moving en bloc. So obviously there will be an addition between the behind the rectosigmoid or the between the rectum and the rectovaginal space. So because of the additions, it is moving en bloc. So this is again a video by the ICOG. So here you can see this is moving separately, but here everything is moving en bloc. So a negative sliding sign tells us there is additions. We need to be careful. So that's why the uterus is not able to move. So I think this is a very simple thing which anybody can do. When we do the ultrasound, also try to move the uterus with a probe. And soft markers, something we know in obstetrics, it just come, I mean, there is importance in the looking for soft markers in endometriosis. There are two soft markers, that is site-specific tenderness and mobility of organs. So again, site-specific tenderness, we can use the transvaginal probe to know whether there is any tenderness in any specific point. And that point, maybe we can focus further to look for a small endometrioma. Then ovarian mobility, normal ovary, we know it is freely mobile. So pressure is applied, it has to be applied between the ovary and the uterus to see whether the ovary is fixed to the uterus. Sometimes we get this kissing ovaries, which is behind the uterus, adherent to the uterus and to each other. So to summarize, look compartment-wise, we have the anterior compartment, the middle compartment, the posterior compartment. Use the sliding sign. In addition to the static imaging of all the compartments, use the dynamic imaging, that is a sliding sign. If it is negative, definitely it requires a more detailed ultrasound by an expert, or maybe that is an indication to do a MRI, that is magnetic resonance imaging in this case, because that will also give us more details whether there is any deposit, site of location, site of the deposit and size of the deposit. And also look for the soft markers, because this site-specific tenderness, maybe it is the first thing that is telling us there is a problem there, which we definitely miss when you do only an ultrasound to look at the uterus and the adnexa and the endometrioma. So TVS is the first first line method for the assessment of endometriosis. Only thing we have to look beyond the uterus, we have to look beyond the endometrioma. And even if you don't see anything, it's fine. You do the sliding sign, that will give you a clue there is a problem. You can refer to a higher center for ultrasound, you can refer for an MRI. Also look for site-specific tenderness when you do the ultrasound. Thank you very much.
Thank you, Dr. Mumtaz. It was really a wonderful presentation along with your beautiful slides and the beautiful videos. I just wanted to know some of the limitations of transvaginal ultrasound. Like the imaging field extends only to the rectosigmoid junction. And if the endometriosis is beyond that, it will not detect those endometrial pockets or something like that. And the depth of infiltration also it cannot judge. So in these cases, definitely, as you told, along with the soft markers, if the soft markers are there, then definitely MRI will help. Yeah, so it was a wonderful presentation again, and you can answer any queries in the chat box because we are falling short of time. Thank you very much again.
Thank you. Thank you.
Thank you, everyone. Am I audible? Thank you, everybody, and thank you, ma'am, for a wonderful presentation. We now move on to our next speaker, and I would like our chairperson, Dr. Rajendra Pardesi, to introduce our next speaker for the session, Dr. Sadhana Gupta. Is Dr. Pardesi there?
You can ask another chairperson to
Dr. Preeti or Dr. Vidya, whoever is available can.
Yeah. I can introduce Dr. Sadhana Gupta.
Yeah, sure, ma'am.
Yeah. We all know Dr. Sadhana Gupta. There is no need for introducing her. She is ICOG Vice Chair elect right now. And she has many awards, many academic publications and honors. And she was organizing chair of many of the conferences. And we know that her presentation always delights the whosoever attends here. So she is speaking on ultrasound in postmenopausal bleeding. And over to Dr. Sadhana Gupta.
Thank you, Vidya, for loving introduction. Thank you, Archana, for involving me in this wonderful masterclass.
Thank you for coming.
And my regards to Dr. Parag, Dr. Sarita Bhalerao, and all the FOXY office bearers. And my regards to Chairperson Vidya Rajan for NDFPT. So I will be covering what is imaging and ultrasound in postmenopausal bleeding. I bring greeting from land of Buddha, and it says Atmadeepo Bhav. So it is ICOG masterclass, and what is there that master and disciple all learn together for the search of truth. So actually there is no difference in master and disciple. We are all on the path of lighting ourselves with the truth and the knowledge. So coming to imaging, because actually nothing exists in vacuum, and we have to know what is our subject, what is the person who is coming with the particular problem before we offer, order, or do any imaging. So that is the basic principle of medicine, and we need to remember and again remember in nowadays when the technology is actually overpowering a lot of human issue in the medicine. So we must have to consider that what is postmenopausal bleeding. So it is any bleeding after 12 months of amenorrhea. Important thing is that around 4 to 11% of postmenopausal women will be experiencing postmenopausal bleeding and coming to us. And when the women are choosing menopausal hormone therapy, they are also coming with the unscheduled bleeding. So why imaging in postmenopausal bleeding is very, very important, because usually the postmenopausal bleeding has benign cause, but we have to exclude malignancy because 90% of endometrial carcinoma present as postmenopausal bleeding is a predominant and the presenting symptom. And 10% of women with PMB, that postmenopausal bleeding, can have endometrial carcinoma. So one thing what we need to exclude with a very good imaging and further workup, that we need to exclude malignancy. And as it is true for every malignancy, the earlier we diagnose, the more favorable prognosis the patient have. So endometrial carcinoma must be regarded as a etiology of postmenopausal bleeding until proven otherwise. So this is something very important, and it is not only endometrial carcinoma, carcinoma cervix, carcinoma ovary, every gynecological cancer also need to be excluded by gynecologists. So that is the epidemiology, that 10% of postmenopausal women coming to us with this complaint. More the age, there is less chance that they have postmenopausal bleeding. And endometrial cancer is bound to increase in recently and in the current future, because there is a pandemic of obesity, diabetes, polycystic ovarian syndrome, as well as late menopause and the small family size. So what is the all risk factor are on the rise in our demography, and that's why we need to be very, very careful that we do right imaging and right interpretation. So first of all, when you do ultrasound or your ultrasoundologist is doing that, we must consider all the differential diagnosis, all the cause which can cause postmenopausal bleeding. So the most common cause is the vaginal and endometrial atrophy, followed by urogenital infection, medicine, fibroid, endometrial hyperplasia, polyp cancer, cervical polyp, prolapse, which is associated with non-cubitus ulcer, ovarian cancer, as well as the non-gynecological cause, because there can be bleeding from the other like urethra and the anus, and rarely vaginal and vulvar cancer. So this is something I think every good ultrasonologist first want to go through our prescription, or you are doing, we want to say what are the clinical findings and what is the special focus of interest when we are doing ultrasound. So this is something very important, and this is also important that the diagnosis, that differential diagnosis of abnormal uterine bleeding in perimenopausal or premenopausal is quite broad. But in postmenopausal bleeding, the differential diagnosis is quite narrowed down, and we can really come to a very good conclusion and the workup plan if we go carefully and with the stepwise. So this is something about art and craft of imaging, and that start again with the history. Like I'm being very, very particular about it, that a good comprehensive history, what is the age of menopause, what drug she is having, a family history of gynecological cancer as well as the colon cancer in male members is very, very important. And this is one thing which I want to say, that in any patient coming to us, this should be our protocol, that any family history of gynecological cancer as well as the GIT and the breast cancer, social history and the smoking. So this is something you need to know, what the risk factor patient is having and what type of patient you are doing that imaging. What is the current reading? What are the associated symptoms? What is good and gynecological history, surgical history, and the medication history. So this is something, and this to be followed by the perispeculum and pervaginal examination for all atrophy, polyps, and the pelvic masses. So with this background, only with this good history taking, good perispeculum, pervaginal examination, and a good risk assessment, we put our probe on this woman who is coming to us with the postmenopausal bleeding. Dr. Archana has already taken a very beautiful deliberation on the endometrium, and this is the principle remains the same, that the transvaginal ultrasound is the mainstay. Because it decreases the need for invasive diagnostic procedure for the woman without abnormality. So it reduces a lot of unnecessary biopsies, unnecessary hysteroscopy, and it also increases the sensitivity of detecting abnormality in women with the postmenopausal bleeding. So transvaginal ultrasound remains the main diagnostic imaging for women with postmenopausal bleeding, because it is less invasive, it is painless, it is accessible, it is low cost, no complication, and maybe more sensitive for detecting carcinoma than blind biopsy. So this is very important test, and that's why you have to do this endometrial and the uterine imaging very, very carefully. So the transducer, it must be the 5 to 10 megahertz transducer, empty bladder. The Doppler setting fixing is very, very important, which should be set on the low frequency, because that is important if you want to do the further color Doppler on this woman after the grayscale imaging. The scan must be coronal as well as the sagittal, and endometrium is measured from the thickest spot from the one bacillus to the other. It should be seen through the entire length of from the fundus. So it is fundus, it is cervical canal, it is the corneal end, which need to have the proper and the full imaging. One issue which we very commonly find in women with postmenopausal bleeding is the endometrial fluid presence. When endometrial fluid is present, then that thickness should not be included in measuring endometrial thickness. And endometrial thickness is measured by subtracting the anteroposterior diameter of fluid from total thickness. So this is something very important thing which we need to consider. And always adnexa also should be imaged in each examination, because the ovarian size of, even the enlarged size of ovary, even the simple cystic ovary, have an important role in managing postmenopausal bleeding at this age. So this is about that, how you say from sagittal, coronal section, from fundus to the cervical end, and the correct measurement, and if fluid is there, you have to abstract it. Saline infusion sonography and histosonography is something which is a gynecologist domain. And this is very simple examination. You put the pediatric catheter and you put a little bit of fluid, and you can differentiate a lot of diagnostic dilemma, like it is a focal polyp, or it is a total endometrial hyperplasia, or it is submucosal myoma. Because every every pathology requires a different mode of, totally different mode of treatment. So this is something which we should accept, which we should learn. And this is a wonderful and a very simple, and takes only just 5 to 6 minutes. And after putting that saline, you examine the uterine cavity very, very systematically from one side to other on sagittal section and then on coronal section. So what you want to see, what are the number of intracavity lesion if it is polyp, what is the surface of that polyp, it is smooth or irregular, size in 3 perpendicular diameter, and we can have a subjective diagnosis that we are dealing with polyp or submucous myoma, which need the different approach for the correction for the treatment. So what are the plus point about the sonohistography? That it gives us idea that what we should do next. We should go for the hysteroscopy. We should do the simple endometrial pupil biopsy. What is the problem with hysteroscopy is that sometime when you enter the hysteroscope, the tissue can overlap and diminish appearance of focal pathology like endometrial polyp. So hysteroscopy has got its own issue, and when in postmenopausal women, uterus is very small. And I will share a few paper where the paper is like document a higher rate of complication after hysteroscopy. So this saline infusion sonography can complement use of hysteroscope. It can guide what we should do next, and it can have a fair idea that what we are dealing, it is a diffuse endometrial hyperplasia, submucous myoma, or the polyp. And the 3D multiplanar imaging, if it is there, it can add to it. So color Doppler after a very good gray imaging, and this is something, whatever is the color Doppler 3D, but it is the well done images of gray scale and the good workup and the knowledge of the background clinical profile of the patient, which actually gives you the major foundation and major step and the thought process to further workup. So when you do color Doppler, what are the role of the color Doppler? That it can give you idea that it can be neoplastic or it can be malignant or not. So if we are having high resistance in sub and intra-endometrial vessel, by RI and PI, it indicates benign pathology. So malignancy, more neovascularization, and you will have the low RI and the low PI. And if it is, you are seeing a polyp, you can see the feeding vessel in the polyp. So color Doppler adds to you, but first the good grayscale, the 2D images are very, very important. 3D power Doppler ultrasound, it is a virtual reconstruction of the endometrial cavity, and it has the potential to study intensity of tumor vascularization non-invasively. So it is important, and one like few studies says that tissue perfusion, 3D tissue perfusion correlate positively with microvessel density count as assessed by immunohistochemical technique. So it has got definitely the add-on role. Now we have a lot of software as well. So it is a vocal TM software which can calculate automatically vascularity index, flow index, and vascularity flow index. Though, so if you have it, you can use it, and especially in certain situation when you find that the basic scan is got the high probability of the malignancy. So there is a 3D ultrasound imaging. This is something I'm saying what is the against the flow that the study, this is demonstrate that 3D power Doppler actually did not add much to the basic ultrasound and the color Doppler. So it's okay if you are having a good machine with a brilliant mind. MRI, I'm just keep touching it because I've kept this thing because now I see on a blink of eye, my time is up. I will take 2 minutes around. So the MRI is only when you have the biopsy proven malignancy, and you have to see the biometrial invasion as well as the tumor spread beyond the uterus. So a simple assessment of postmenopausal bleeding in most of the time does not need any MRI. So this is something that this MRI, which is showing that there is no deep myometrial invasion, and it is after the proven like a proven malignancy. So atrophic endometrium, it is what we find in the postmenopausal woman. It is a basalis and basalis layer. it is thin and hyperechogenic, we are always very happy if it is a thin atrophic endometrium, because we can treat it very well. We can reassure that patient is not having malignancy. And if the patient endometrial thickness is less than 4 millimeter, endometrial atrophy is assumed to be cause for the postmenopausal bleeding. So endometrial hyperplasia, you have to calculate right endometrial polyp, focal hyperechogenic, and endometrial carcinoma, which is showing the high vascularity, thickening more than 11, 12, 20 millimeter, and with a low vascular impedance. Cervical carcinoma and uterine leiomyosarcoma are rare cause, but cervical carcinoma is still there in our country. They don't have any pap smear. And if you see any solid heterogeneous cervical lesion, which is dispersing a good microvasculature, we have to go through again if the perispeculum or the examination has not been done. And myoma, which has got the peripheral single vascularity, versus leiomyosarcoma, where you have a very good vascularity, and the inside the myoma you have found it is not only at the periphery. So these are the pictures what we find in the women with the postmenopausal bleeding, thin endometrium, hyperplasia, polyps, and cervical carcinoma, which is something, it is like a very, very important diagnosis, myoma and the leiomyosarcoma. Important thing, sometimes the TBOS, this cannot give you the exact or the optimum idea because of axial uterus, obesity, coexisting myoma, adenomyosis, and previous uterine surgery. And if you are not very sure that you are not able to look at uterus, you are not able to look endometrium properly, then go for sonohysterography, office hysterography, or the endometrial sampling. And this is very important limitation which we have to consider. Endometrial hyperplasia is not radiological diagnosis, it is histological diagnosis which need to be confirmed with the endometrial biopsy. So this is very important. And the another thing is that if you have done biopsy and there is in like a normal report and the woman is coming repeatedly with persistent bleeding, then she should be evaluated properly. Women on postmenopausal hormone therapy, we have to consider that she is on MHT, and that is important that we should care what are the type of findings. So this is the image what we have in the menopausal hormone therapy. And always do ultrasound if the patient is coming with breakthrough bleeding in the first half of the cycle. So this is important. And endometrial thickness, if it is more than 4 millimeter, it should be used to cut off mark for the further investigation. So that is very important. Polyp, you have to say what is the type of polyp. It is feeding vessel, it is single polyp, or the multiple polyp. And if polyp is symptomatic, it needs removal and the pathological, histopathological examination. Submucosal fibroid need to be differentiated from endometrial hyperplasia. And when the woman is in tamoxifen, very, very careful because they are prone to have the endometrial malignancy. So my point is that you have to have a good history, that patient on MHT, patient on tamoxifen, if she had the previous ultrasound and she was having leiomyoma, has there been any change about it? So this is important. And this is one very important point, that even if endometrial thickness is less than 4 millimeter, sometimes it can be endometrial malignancy because it does not reliably exclude type 2 endometrial carcinoma, papillary, serous, mucinous, and clear cell carcinoma. So though we say if it is endometrial thickness less than 4 millimeter, we can mostly say that she is not having malignancy. But if she is coming with recurrent bleeding and she is having thin endometrium, even then she needs a proper evaluation. One last question which we have to answer: should we screen asymptomatic low-risk postmenopausal women for endometrial thickness less than 4 millimeter? Or incidentally, you are doing ultrasound and you find in postmenopausal women endometrial thickness is 5 millimeter. So it is a wonderful paper in 510 women in Sweden, which have the asymptomatic women who are coming with the increased endometrial thickness. The important point which I want to highlight, that out of 29 of the 34 women with focal lesion, they were offered biopsy and the hysteroscopy. And all patients had the benign pathology But the two women with complex hyperplasia with atypia underwent hysterectomy. So it was the two women, they found that it was a pre-malignant condition, not malignant. But the highlight of the paper is in two women who underwent hysteroscopic surgery, uterine perforation with bowel damage occurred, which needed bowel resection with ileostomy, and focal lesion could not be removed. And in second case, bowel resection and anastomosis was performed and focal lesion was removed. So the lesson learned is that asymptomatic women with incidental a little bit thickening of endometrium should not be subjected to full evaluation or the hysteroscopic directed surgery, because we are gaining much less and we can have the potential very, very serious complication. So this is one thing, it is important, this message, that it need not trigger any evaluation. Endometrial biopsy when to consider: when the endometrial thickness more than 4 to 5 millimeter, patient is coming repeatedly with the bleeding episode, showing diffuse or focal increase echogenicity or heterogeneity, endometrium not adequately visualized on sonography. So we have to be very earnest that we are not able to assess endometrium properly. Woman is having persistent bleeding and woman with the high risk for the endometrial carcinoma. What we do when the recurrent bleeding following negative evaluation, no consensus, but always keep these women in the good follow-up. So this is what I have said is summarized in the ACOG committee opinion in 2018, that it is a TB, transvaginal ultrasound is a very good alternative to endometrial sampling, a very good trials tool. And when we find that we are not identifying a thin distinct endometrial echo in postmenopausal bleeding, we should go for the sonohysterography or endometrial sampling. And if the insufficient sample is there, then hysteroscopy with the suction with the diagnostic ureter. And likewise, the asymptomatic woman with the thick endometrium usually does not need the biopsy, just they have to be kept on the follow-up. So this is something what I have summed up. So I'm not going with this details. The key points that the transvaginal ultrasound imaging in a woman with postmenopausal bleeding is not only better tolerated by patient, it is effective and cost efficient mean, it is friendly, effective, and we have to have a very clear like a protocol for it, that what type of woman we are having, what examination is suggesting, what family history is suggesting, and then endometrial thickness, which need the endometrial simple sampling by pipette or by the hysteroscopic DNC, and the few patients who are having the asymptomatic, but the thick endometrium, they does not need evaluation. But if the patient is having even thin endometrium, but she is coming with the like a recurrent bleeding, the patient need full evaluation. But because endometrial carcinoma can exist even with the thin endometrium, whenever needed, the 3D Doppler and the color Doppler will add to your diagnosis. So education is not filling of pail, lighting of a fire. I really thank everyone to choosing me, electing me ICOG Vice Chair elect. Join ICOG. We need to think fresh. We need to work for the holistic medicine, because life is beautiful and we have to give time, especially to our elder women. Thank you very much.
Thank you very much, Dr. Sadhana. It was exhaustive, and you have covered almost all the points for the postmenopausal bleeding and its evaluation. Thank you very much.
Thank you so much, ma'am, for the lovely detailed lecture. I would now like our chairperson to introduce the next speaker, Dr. Vidya Bhatt. So over to you, ma'am.
Thank you so much, Anshu. At the outset, am I audible?
Yes, ma'am, you're audible.
Audible, okay. Very much audible.
So, thank you so much, Dr. Archana, for inviting me to this prestigious platform, and extremely thankful to the ICOG office bearers. A wonderful talk, Dr. Sadhana. The only important thing that I want to highlight is sometimes you get, patients, postmenopausal bleeding is very, very alarming. Every time, patient is also anxious and the doctor is also anxious. So once with the one episode, if you do a scan, 2D, you said it's the first tool. So once you do a scan, you find a thin endometrium, maybe less than 4 millimeter. Then also, please keep on observing that patient, because sometimes, because of the bleeding, the endometrium may be thin. So it's very important to keep those patients also under observation, repeat the scan maybe after a month's time and see the thickness, whether it is increasing or not. Sometimes because with the bleeding, the endometrium can look, thin, and it may not be more than that cutoff. So that's the only point. And many of the times, yes, you mentioned that recurrent bleedings definitely need a lot of attention. Thank you so much. And now I move on to the next very eminent speaker, Dr. Vidya Bhatt, a very close friend of mine. She's a laparoscopic surgeon and an infertility specialist, a very humble person, I must say. She's a medical director, Radha Krishna Multi-Speciality Hospital and IVF Center, Bangalore. And she has conducted several live demonstration on laparoscopy and hysteroscopic surgeries. And she was also here when we did IEG at Lucknow. She had been invited as a faculty at various international and national conferences. She has held several posts and positions in Kasoga, and also she had been an ICOG member and joint secretary to FOXI 2013. And she has a lot of publications as well. So she's going to speak on cesarean scar niche or sphymocele, which we quite often miss. I think a part was covered by the previous speaker. And it's very important when you scan, sometimes they may be symptomatic, sometimes they may not be symptomatic. So let's hear to Dr. Vidya Bhatt on cesarean scar niche or sphymocele.
You can share your screen now, ma'am. Dr. Vidya?
Ma'am, Vidya ma'am is not joined yet.
Oh, she has not joined?
Okay.
No, ma'am. Please call her and ask no whether there is any net issue or something.
Because Dipti has been so particular in calling everyone. So I think Vidya, let's see what's happening.
Somebody calling Dr. Vidya?
Yeah. It's not able to connect.
I think
So
Dr. Vidya has not joined, so maybe we can
let's
sum
wrap up.
We can wrap
Sum
up.
up. Yeah.
Because
Sum
wrap
up.
up as such, we have like on time for ICOG things. So Dr. Preeti, just your inputs on the whole thing. I think
I think it was a wonderful, session, and I was there right from the beginning. Dr. Archana, your talk was very, very good, very informative, and we should have such kind of, lecture series. The ICOG Masterclass on ultrasound was very informative, and I must suggest that you should have one for obstetrics also. Because that's also very, very important. This was very pertinent when we were talking about how you planned it, right from the basics to, how the follicle monitoring. Dr. Beenu Agarwal covered it very nicely about Dr. Mumtaz talked about the endometriosis, and a wonderful case presentation. Dr. Deen Dayal presented a very nice case series on infertility. They were very informative case series, and we learned a lot about it. So at the end, Dr. Sadhana Gupta's talk that was on postmenopausal bleeding, that was also very informative, and she touched upon a very, very practical points that besides, the ultrasound, the history, the examination, it's very important because sometimes that you may get the clue, and clinical examination will definitely rule out the lower genital tract abnormalities and problems. So ultrasound plays a very key role. A basic 2D, every OBGYN should know about it. More such cases are required. I think we'll have a post test after this session. so we can move on to the post-test series. And wonderful speakers and all the chairpersons also commented very nicely. And congratulations to you, Dr. Archana. I have heard you yesterday also, your talk, and then today also. I love your presentations, and I always want to attend your academic sessions. Thank you so much for making me part of this, and wish you all the best for all your endeavors. So with this, I conclude, and whatever you want to say, Dr. Archana, you can just conclude this session because you are the convener for this entire series. And Deepti, Anshu, everybody was, all were fabulous in conducting the sessions.
So, I mean, now I would like to thank all from bottom of my heart, ICOG office bearers, Foxy office bearers, and especially all the speakers. Those, like, they are all friends, and I've heard them say, like, we have interacted on several platforms, and they've been there for me for every workshops, whether it is a FMF Foxy course or ISAR or Foxy, everything. So my very thanks to Dr. Mumtaz, Dr. You could, I mean, the delegates, you can give a direct this thing. This we were used to do in our FMF program. If I'm not
Yeah, that
mistaken,
FMF
we used
programs,
to
no,
do
like that.
like
Yes,
4
yes.
or 5. They'll select 4 or 5, and then we'll answer. I think we can incorporate that in the future
Yeah, in the
things. Yeah,
next
Dr.
class,
Vidya
next.
Thobi is now here with us. Welcome, Dr. Vidya.
Vidya
Dr.
Bhatt.
Vidya Bhatt.
Oh,
Dr. Vidya
Dr.
Bhatt.
Vidya.
ooh, sorry.
Okay, she
Because
has
I've
joined.
heard Vidya
Vidya is
before
joining.
on her Istomosil talk, and I really wanted
The people wanted that. People are asking in the chat box, where is the next talk?
Yeah, I
So,
know, because Istomosil
yeah.
is like so many times we are picking up Istomosil. Now it is
Yeah.
becoming like a common because of the increasing cesarean section. So Dr. Vidya, please come.
Dr. Vidya, you have been introduced already.
I'm not able to see her in the.
I sent her a message and I spoke.
Ma'am, she is not joined yet.
Yeah,
She
I
will
spoke
join.
to her.
If whether she has confirmed that she will join.
Yes, yes, I spoke to her personally, to Vidya, and I had her message, and we have sent her emails and all. So
No, now she contacted.
I spoke
No.
to her just now.
Good that Dr. Sadhna, we allowed her to speak and complete her talk.
Yes.
Otherwise, I would have felt bad if I would have stopped her in between.
I think Istomosil is a very important topic. We just wait for 5 minutes if
Yes,
Vidya
yes.
can join. Otherwise, in the next meeting, even if we are doing obstetrics with cesarean section scar thickness,
we can take that class.
In that
We
series,
can
we
take.
can join.
thickness,
We can
and
take.
how to measure scar thickness in obstetrics, I will include the Istomosil as well.
That would be good. That would be good.
You can conclude this session.
You can conclude this session because most of the participants have left now.
Yeah. Only 84 have left. Are there right now?
Vidya has joined.
Dr. Anshu, you can conclude the session, and we can just.
You tell Dr. Vidya that her talk will be taken up in the next session.
In the next, yes.
Just joined, madam. Dr. Vidya just joined.
No, you are reading Vidya Thobi, then Vidya
No,
Bhatt.
Dr. Vidya Bhatt is joined.
So what about the post-test, Dr. From ICOG team? Nilima, are you there?
Dr. Nilima?
She may not be here.
Ma'am, if I'm not mistaken, the certificate course, the 3-day certificate course has a post-test at the end of...
There was no pre-test for this, na? Masterclass.
No, madam. No, ma'am. Masterclass.
So there is
will
no
be no
post-test
post-test.
also. There is no post-test.
No post-test.
Okay. Okay, so I think we wind up, and thank you everybody for
Thank
being
you.
here and
second,
for your inputs. Well taken your inputs, and thank you team ICOG Masterclass Ultrasound, Dr. Deepti, Dr. Anshu,
Vidya
and
joined
Dr.
now.
Vikas.
Vidya joined now.
Really putting up a good program.
Extremely sorry, I was in a
No,
case.
Vidya, we are winding up now session.
Okay, then no problem.
Because
Dr.
people,
Vidya.
what we will do now, only 78 people are there.
No, it's okay. Let's listen to her. No, then it will be recorded, and then ICOG can.
Please
wait
record
later.
Vidya's talk then. Yes.
Yeah,
If you're
Vidya,
okay,
come
I
on.
will give. Otherwise, I will.
No, you continue now. You give.
Continue.
Vidya, we are okay with you because we really want to hear you.
Okay, thank you so much.
Yeah,
I'm
thank you.
my privilege, I'm blessed.
Thank
Dr.
you.
Vidya, I introduced you.
Yeah.
You were not there
We
in
have
your
already
absence.
introduced you.
Extremely sorry about it.
So come,
Extremely
let's
sorry. I
start
was
playing Dr.
delayed-
Vidya's.
got delayed by a case. Yeah. Yeah.
Make it full
Thank you
screen.
so much
Yeah,
for
yeah.
this opportunity. There was a confusion because my same lecture I gave for the ICOG endoscopy students. So I got confused. I thought I had done with it, but I didn't know it was for the same masterclass. But I'm extremely sorry about that, but thank you for considering me. And now let me talk about this isthmocele. Isthmocele, niche, previous LSAS scar defect are some things which we routinely see. This is a new disease. With the advent of the newer techniques and more and more cesarean sections, this has been a problem. It has been diagnosed also, and now we are trying to prevent it. So isthmocele is a cesarean scar defect following cesarean section, which involves myometrial discontinuity at the site of the previous cesarean scar. It is commonly seen on a transvaginal ultrasound like a wedge-shaped anechoic area. Symptomatic cesarean scar defect is commonly reported as a long-term complication. It can be misdiagnosed as a fibroid or an adenomyosis or a bladder mass. So in the past, over a past decade, this has increased because, the incidence of cesarean section has increased, and the diagnosis also has increased basically because more and more gynecologists are doing transvaginal scans and they can relate to it. Maybe if it is a sonologist or a radiologist, they may miss it because they don't commonly see that. Sometimes it is mistaken for even a small Nabothian cyst, but this is how a cesarean scar defect looks. Here it is round, it can be wedge-shaped, it can be pear-shaped. There are different shapes for that. You can diagnose it even on hysteroscopy and even on HSG. When you start treating patients for secondary infertility, you can identify this. Now, the different nomenclatures for this niche: isthmocele, uterine diverticulum, uterine scar dehiscens, or uterine dehiscens, and uterine pouch. So these are some of the things which it can cause problems. That is, there can be, several hypotheses to explain this. When it is a very low incision, impaired wound healing, adhesion formation, inadequate suturing in a hurry, there is a lot of hematoma formation, or whenever there is a congenital anomaly. In typical important causes are classical C-sections, labor before C-section, that is second stage, previous uterine trauma, that is especially if there is Escherman's or too much of interference into the uterine cavity. Single layer closure. This is what we have been seeing. Single layer closure, everybody is in a hurry. The Misgav Ladakh came into picture where we said, okay, don't close anything, just suture fast and come out. Abnormal placental implantation and inappropriate oxytocin administration. That is, we want the patient to deliver fast and we give so much of oxytocin without control. That can also lead to this. Then, of course, the additional factors: diabetes, emergency surgery, infection, incision very low, and nulliparity sometimes. So this is all the normal scar and the different types of isthmocele. You have complete and incomplete isthmocele. The myometrium is disrupted, but the serosa is intact. Full thickness tears of the uterine wall result in uterine ruptures. These ruptures may mostly occur at the level of the cesarean scar, though they say 0.1 to 0.5%. This, when the defect is really more, that is more of serosa involved, there's no myometrial lining, it can lead to more ruptures, and these can be sometimes scary also. Compared to complete uterine rupture, uterine dehiscence has much lower maternal and neonatal morbidity. So classification, you have a triangle shaped isthmocele. On ultrasound, you can make out the different classifications: triangle shaped, then semicircular, you have a rectangular shape, then you have a circle, then you have a droplet kind of thing, or multiple inclusion cysts or incisions you can see. So these are all different types of isthmoseals which you can appreciate. The location and shape, most of the time it is anterior uterine segment, uterine body, uterine isthmus, endocervical canal, depending upon where exactly the incision is taken. The pouch side focal defect could be their shapes, thin linear defect, unilateral, like a dog ear, you can see, or a fistula. So there's no universally agreed classification, but more than 50% loss of the myometrial scar mantle at the scar level, and depth accounting to 80% of the muscular layer that leads to the scar dehiscence. Impact of isthmosele, approximately 30% of women with this niche report with spotting in 6 to 12 months after cesarean section. Most of the time it is irregular, brownish discharge, and sometimes they can come with infertility also. It is usually associated with obstetric complications. So the previous scar defect, called as, also known as scar diverticula, deficient area, and is a serious complication of cesarean section with prolonged bleeding, dysmenorrhea, abnormal uterine bleeding, infertility, and sometimes there can be deep dyspareunia. So how does this cause women's symptoms? Irregular bleeding, pain, and infertility. So irregular bleeding, I showed you, pain because the menstrual blood collects there and there is some amount of uterine contractions, and this can also lead to scar ectopic pregnancy when this defect is a little huge. The sac implantation may be there, and secondary infertility because the sperms do not flow into the cavity. They get into this niche and maybe they are destroyed by the clots there and the long-standing infection. There can be chronic endometritis, so that leads to implantation failure. So this is a hysteroscopic scar ectopic. See, you can see that the whole niche area, in that the scar ectopic is there. So this clearance has to be done. And the measurements you have to do with the myometrial defects, you will have to see the scar width, the depth, and then the deficiency ratio, that is remaining myometrium followed by the intact myometrium. That's how you differentiate. Most of the time in a hysterectomy patient, now the incidence of hysterectomy is also coming down because of the High Court rules, and then the newer methods of treatment for abnormal uterine bleeding. But in a scar, hysterectomy scar, you can see this niche. So, and then there is collection, and probably there is a lot of infection also there. So the diagnosis what we make is with the TAS, yes, but TVS, it is more evident. 3D ultrasound, sonosalpingography, HSG, yes, MRI also, this defect can be diagnosed, but that will work out very expensive. So it is a very simple, non-invasive, low-cost choice to consider screening, because 100% you can know, and then you can correlate with hysteroscopy in a transvaginal ultrasound. So once you diagnose it on a transvaginal ultrasound, you have to see the myometrial thickness also. If you come to know the myometrial thickness, then you know exactly that whether you have to go through the hysteroscopic route, can we do it with the vaginal route, or do we have to put in the laparoscope? People are talking about robotics. I think last AAGL when I went, people were saying we can do it with robotic surgery. I think it is Brahmastra for a small problem. So try to learn to tackle this by hysteroscopy, vaginally, that is elevation of the bladder. You go through the vaginal route, and of course laparoscopy. So 3D with zooming, these are different kinds of 3D images to show you the cesarean scar defect. And saline contrast, when you put the saline contrast, you can see the saline entering into that defect. So there is some amount of depth there. So the fluid gets collected and you can see the defect easily. So then, of course, HSG is done, and this is the extension of the dye, and HSG, now nobody does. You can pick this up on ultrasound only. So HSG will be an extra exercise, which may not be necessary. MRI also, it's a very expensive tool. So if you diagnose it by TVS and then put in a hysteroscope, office hysteroscopy, I would say as a hysteroscopic surgeon, office hysteroscopy is a beautiful tool for you to diagnose it. And then you look for chronic infection. If you can tackle it, without any surgery, you can go ahead. But if the lesion needs surgery, then of course you can use the resectoscope. So treatment is basically eliminating the other causes of infertility. Basically, these are not symptomatic, but sometimes about 60% may be symptomatic. The other 40 to 50% may just be asymptomatic. So depending upon the parity, the surgical risk, the symptoms, and infertility, you have to tackle this problem. So symptomatic isthmos desires further fertility, completed family, then don't try to do anything. If they are symptomatic, then put in a hysteroscope, try hysterolaparoscopic approach. Conventional vaginal, there are very good vaginal surgeons who do this. They just lift the bladder up and then identify the scar defect and suture it. That's also, I feel it's a very beautiful technique, because vaginal surgery is an art, and if one can do it by vaginal surgery, nothing like it. So transvaginal repair, that is, you identify the defect and then you correct it. With the resectoscope, yes, you make incision and then you align it with the uterine cavity. Then laparoscopic approach, when you're almost near the bladder, that is there, it's just a thin serosa, then don't try hysteroscopic method, go laparoscopically. Suppose you're not confirmed with your diagnosis, then identify hysteroscopically and go through the laparoscope. And robotic assisted, I'm not for this, but people are doing. But see, vaginally, it's so beautiful. You open the flaps, you push the bladder up, you give in a little vasopressin there, identify it, and then suture it. So vaginal repair is really good. They have also injected adrenaline. I don't think that video of mine is working. It's not my video, my friend's video, but it is I think these are the steps. I don't think that video is working, but vaginal approach is excellent for this. Just push the bladder with the skilled vaginal surgery, and the repair is minimally invasive, good exposure, accurate resection. Contradictingly, there are many studies which have shown this as a minimally invasive treatment. Hysteroscopic approach, yes, there is a pouch hysteroscopically, but at least you should have some amount of myometrium, that is at least 3 to 4 millimeter of the myometrium has to be there, and then resect the fibrotic area. So what do? You put in the hysteroscope, identify the defect, that is your uterine cavity is normal, there's nothing inside the uterine cavity. Then what you do, you come towards bring it out. As you bring out the hysteroscope, you can see the blood collection there in that niche. Can you appreciate that blood collection there? And then you know that there is a pouch or the niche there. Then you go in with the resectoscope. You can't do it in office method. Office or ambulatory hysteroscopy is just for your diagnosis. So once you have this, you put in your resectoscope and make multiple cuts there on that niche wall. So once you make this cuts, you know how much of the depth of the scar tissue you will have to remove. So once you identify this, all you have to do is just remove that, or you cut that, and then what you do after making this incision, then align it. See, you made that depth incision. You can see like a Mickey Mouse ear, no? So we have made that incision, and then you take the resectoscope loop. This is the loop. What I showed is a thin cylinder, the previously shown one. And now this is a loop, and then this gets removed. So this is something, a hysteroscopic view, it is very good. And if you can do it hysteroscopically, isthmoplasty, it's a very popular treatment. So laparoscopic repair, of course, when the myometrium is very thin and then you can't go through hysteroscopically, then go through the laparoscopically. And see here, this was one of the approaches where I had to go through with the laparoscope. But the problem was it was badly adherent, because it was ventral suspension of the uterus. And as I was going, you can land up with this problem. As I was separating, you can see that I just opened up the bladder. So when there are chances when it is very thin, when the approach is not, when you don't get the plane, there are chances, but don't worry. When you have opened the bladder, you come and explain it to the patient, and then suture it in 2 layers, and then get to the proper plane. See, once after that, after suturing the bladder, you know the bladder extent, adherent area, then you come to the proper plane. See, you can identify the proper plane now. Sharp dissection was done, and then the isthmocele was identified and it was sutured. So histrolap approach of the isthmocele, when you're over enthusiastic, you can just open up the thin area. So that possibilities are there, but you have to be careful and treat it properly. Robotic assisted, well, I'm not for this, but people are doing. And isthmocele and infertility, we are seeing a lot of patients, basically because there is mucus, obstruct the spermal, the spermal swim, it'll obstruct, it'll interfere with implantation also. So isthmocele has to be corrected in cases of these complications. So other complications, you have abscess, bladder injury, which I showed you, and then how to prevent. How to prevent this? Reducing C-section scar rates. Double layer non-locking sutures of cesarean section has to be taken, and avoiding second stage cesarean section. So to conclude, diagnosis of isthmocele has to be made early. Decision of correction of the technique should be depending upon the type of isthmocele and the skill of the surgeon. So thank you very much for your kind attention. And sorry again
Very
for the
nice.
confusion.
Excellent talk, Dr. Vidya. I must clap for you.
Thank you.
Dr. Vidya, just one question. I think you have nicely covered when to do hysteroscopically, when to do vaginally, when to do laparoscopically. I just wanted to ask, is the scar defect or niche is also present when you do myomectomies during cesarean?
Myomectomy during cesarean? No. This is not there. That is basically because myomectomies, what will happen is it is on different areas. And then when it is a myoma, we suture it with barbed sutures. So this problem is not.
No. During cesarean, suppose if you have done a myomectomy, do you get
I have
niche
done a
after
lot,
that?
ma'am. Actually, I have a series also, and I have done a lot of myomectomies, but there we suture it with barbed sutures. So when you use barbed sutures, the approximation is good, the hematoma formation is less, and the scarring is also, I mean, it's approximated well. So
No, you're not getting my question, Dr. Vidya. I'm just
here?
asking, many of the OBGYNs, they do myomectomies also during cesarean section. So
Yeah.
have you seen scar defects in myomectomy scars also?
No.
Can I make a point here? Can I make a
Yeah.
point? So Dr.
Yes.
Preeti, if we open the uterine cavity and then we close it, then from inside the cavity the healing has not happened, and that is where the niche will form. But in a fibroid, we are not opening the cavity.
Yes.
No, sometimes we open. It's
Yeah,
sometimes
even if
there's a
we
very
have opened,
you do open the cavity sometimes.
Even if we have opened, it doesn't happen because when it is myoma, see, when it is a cesarean scar, our closure is in a different way. But when it is myoma, we always respect the cavity. We approximate it with this regular vicryl, and then we suture it in 2 layers. So the approach is entirely different.
So you hardly see niche in myomectomy scar.
No,
hardly
yes.
see.
Hardly
So, and
no.
second question is second question.
Vidya, Archana, the important thing is a brilliant presentation, Vidya. That this we have to take in ICOG, that how we can prevent scarnish. Because a single layer closure and the timing of cesarean section in advanced labor or much before labor, actually it is not a good thing that we are having suddenly in last 2 years, we are having a lot of scarnish and scar weakness. So this is something about cesarean section technique, and it is almost totally preventable if we take the account of a right technique and the right timing, and mentioning it in our discharge ticket that at what time it is being done. So
just one more question, Doctor. Sorry to interrupt, Dr. Sadhana. I just wanted to clarify one more question with Dr. Vidya. Suppose if there is an asymptomatic isthmocele, and if you have seen the thickness, it's only serosa, and the patient is wanting to plan a pregnancy, then also you will not, operate on that patient. She's asymptomatic. Suppose you have done a scan. She's asymptomatic. She's planning a pregnancy.
See, we don't operate, but we tell her that the scar dehiscence chances are more in this.
So would you not like to repair
Better.
before?
It is always whenever it is serosa, then she is prone for scar dehiscence at least by 30 to 33 weeks. So we should offer her this
surgery.
Procedure is there. So it would be ideal for you to undergo this procedure and then plan a pregnancy.
But you know, Dr. Vidya, not
Vidya,
many,
your
not
comment on
many.
Preeti is
Sorry.
Thank you,
important
Dr.
question.
Vidya. Thank
One
you.
thing,
Everybody.
Secondary infertility itself is one of the presentation of scar, Nishna. Secondary infertility can be the cause for the secondary
Yes, ma'am. Yeah, because
Dr. Vidya,
first thing is there is a pouch. There is lot of the clots inside that niche. Second thing is it will lead to chronic endometritis because of those. The problem is we do not identify chronic endometritis, and chronic endometritis is a big problem. Almost we see 18 to 22% of people suffering from this, and infertility is pretty rampant because implantation will not take place in them.
Any reason why nulliparity and diabetes patient they are prone for niche? Any reason for that? Nulliparity, as you mentioned, is a predisposing factor.
Nulliparity is what happens is sometimes when there is no good healing. Diabetes, of course, there'll be infection, ma'am.
Okay.
Yeah.
So even anemia can be one of the predisposing.
Can be one of the reasons.
Sadhana madam, just one thing, you mentioned that it is become common now. So they have actually shown in DUB patient, they have done a hysterectomy in I think 50s, 60s, Dr. Vidya will agree with me. The cross section, they did not know what it was. And now in retrospect, they have found it was actually
we have learnt about this new disease now.
I think it was there, but we were not able to diagnose it.
Yes,
I think the diagnostic modality which is in our hand today has armed us and really given us insight into this problem. So problems were there also before, like adenomyosis and all, but we are learning about them now in a better way. So I think it was worth waiting for your lecture, Dr.
Yes, definitely.
And I think for the confusion and
no, it's okay. It's okay. I think we are reminded, but your phone call somehow I couldn't understand the language. Like
I was operating, ma'am. Sorry.
So it's okay. It's okay. So I think it was a really wonderful,
very nice talk.
and
Very
good
nice.
session. I'm happy with the today's session. What I have learned that you should be happy that like everybody has done so much justice to the topic.
I have learned so many things.
Yes. So thank you, everyone, and we meet
Thank you.
again. And thank you, Dr. Vidya.
So, Dr. Vidya, it was worth waiting for your talk. I joined at 4 o'clock. So it was worth waiting for your talk.
Thank
you so much.
I'm honored.
Thank you, Dr.